Good morning, Samir.
Very good morning. How are you?
Good, how are you?
Good.
Thank you for doing this for us. We see very low, unusually low participation today. I'm just going to see if we can get the Zoom link sent out. I don't know if there was a mix-up or something happened.
No problem. We can wait a few minutes and see.
That sounds good. Thank you very much. Okay, I apologize for that, Samir. We are sending out another email. I'm getting emails now that people kind of got the wrong information. We should have more people joining in. But we can go ahead and get started because this is also being recorded, and then people can review later if that's okay. Perfect. I'll go ahead and introduce our first speaker, Dr. Samir Kapadia. Dr. Samir Kapadia is the chairman of the Robert and Suzanne Thomas Department of Cardiovascular Medicine, Seidel and Arnold Miller Family Heart Vascular and Thoracic Institute at the Cleveland Clinic. He is a professor of medicine at the Cleveland Clinic Lerner College of Medicine of the Case Western Reserve University. Dr. Kapadia specializes in percutaneous treatment for valve diseases, including transcatheter aortic valve replacement and specialized clips for mitral regurgitation, as well as complex coronary interventions and other structural heart disease interventions, including paravalvular leak, atrial septal defect, and PFO closures. Dr. Kapadia has been on the staff of Cleveland Clinic since 2003 and served as the director of the Soames Cardiac Cath Lab since 2009 and as the section head of invasive and interventional cardiology since 2014. He earned his medical degree from NHL Municipal Medical College in Gujarat, India, and completed his internship and residency at Baylor College of Medicine in Houston, and then continued to his fellowship in cardiology and interventional cardiology at the Cleveland Clinic, where he also served as the chief interventional fellow. He is an active member of various national cardiology societies, including the AHA, ACC, and the Society for Vascular Medicine. He has authored over 450 peer-reviewed articles in leading journals. He has edited Cardiology Board Review Book and Textbook of Interventional Cardiology, Dr. Kapadia is a dedicated researcher, educator, innovator, and devoted physician to many of his patients. I had the pleasure of knowing him personally during my stay at Cleveland, and I can also say he is an amazing individual and a great father and a husband. He is going to be talking to us today about PCI post-TAVR tips and tricks. Thank you so much.
Thank you very much for the kind introduction. Now for the last 1 year, I'm a chairman of cardiology at Cleveland Clinic. So I no longer am the Cath lab director. So we have a new Cath lab director, Dr. Ankur Kalra, and also he is also our section head for interventional cardiology. I want to start with the presentation. So I'll share my screen if it's okay with you. And I'll minimize this part so at least it doesn't come in the picture. Okay, first of all, thank you very much for inviting me. And what I'm planning to do is to talk about the post-PCI, post-TAVR PCI as my main topic. And then in the end of it, I'll also talk a little bit about the management of coronary artery disease in the patients with aortic stenosis. This is important because when you are going to talk about the coronary access, both of these things go hand in hand because how we decide who is going to have the coronary intervention or not. So the first question that is important to understand, just like how whenever you do a first angiogram or when you do angiography, you need to know the anatomy. So the same way you need to know the anatomy of the valves, because if you do not know the anatomy of the valves, it is exceedingly difficult to manipulate the catheters and to plan accordingly, decide what guides to use and how to access the coronary arteries. So there are 3 valves that are currently available in the United States that are commercially available. The Evolute are the Sapien family of valves because they were available before. Evolute families were available before. So many patients nowadays present with these different types of valves. And then of course, the Lotus valve that recently got approved in the United States. I'm not going to focus too much on the Lotus valve because it is very difficult to access the coronaries from the frames. So you have to access it from above. So if you're going to plan the Lotus valve, you have to plan it in such a way that the coronaries are not low. With that in mind, if you look at the coronary heights, so there is this yellow bar that has been drawn there. So the coronary heights, again, heights vary from 10 millimeters to 25 millimeters, but most of the patients that we select have the coronary heights anywhere between 10 and 15 millimeters. Maybe the average it says is 18 millimeters. It is very important to understand that different sizes of the valves and where they are placed. So if you say the basal plane, so that is the plane that you see here. So compared to the basal plane, if the valve is placed, let us say 2 or 3 millimeters below, and then how far are each of these cells and how much each of the cells are covered is very important to know. And where the commissures are of the valve is also very important to know because if the commissures are present just in front of the coronary arteries, then it's difficult to access them. And I'll go over all these things and how to identify these things fluoroscopically. So again, to highlight that the coronary heights, when people measure, they measure mostly from the center of the coronary artery. Many times it is worthwhile to know the diameter of the artery because, as you know, the left main can be 5 or 6 millimeters. So you can have a 6 millimeter differential between the heights, depending on where you measure the height. So this is also very important information to keep in mind. Now, I'll start with the Sapien valves. So the Sapien, before the Sapien 3 was Sapien XT. Sapien XT had 3 links, 1, 2, and 3. And the bottom 2 links were covered with a cover. So you cannot come out of these bottom 2 links with a catheter. On the other hand, the Sapien 3 as you can see, is designed like this, where the top link is larger and the bottom links are smaller. There's also a cover on it, but the cover doesn't matter for coronary access. These 3 cells underneath the larger cell are covered with the cloth. So there is no way to access, no way to come out of these 3 areas with the catheters. The catheters only can come out from the top. Very importantly, it also has these commissures that are marked, in the sense that if you look at this, so there are 12 links of the SAPIEN 3 valve. If you see that this is the commissure, the commissural post, and then if you go 4 around, 1, 2, 3, and 4, you will see another commissural post, and then another commissural post. So 1, 2, 3, and the 4th one has a commissural post. You can see these things on fluoroscopy in the SAPIEN 3 valve. So here is the aortogram on the SAPIEN 3 valve. And here you can see that you have a little double link that you can see here. You see that this link is not one bar, but it has 2 bars. If you see this on this side, again, you can see that this has 2 bars, this has 2 bars, and one in the front must have 2 bars, because if you go 1, 2, 3, and 4, this is an RAO view, this is an LAO view. So normally the coronary ostia and we will go over this in the RAO view, our left coronary ostium is here, right is here. And if you look at the coronary ostia on the left side, the left is there and the right is here. So for this particular valve, it is very possible that the post is fairly right across the coronary artery from the left side. Now, if you look at the LAO view, it is sometimes tricky to know that that particular post is in the front or is in the back, because LAO view is very difficult to tell which is in the front and the back. The best way to know that is that if you get rid of a little bit of cranial angulation, remember that the front of the aortic valve is always higher than the back, because the aorta goes from anterior to posterior. So the front of the aortic valve is a little bit higher than the back. So what happens is that if you look at just LAO view, if this post is higher than that, that means it's in the front. If this post is lower than this, then it is in the back. So that way you can tell where each post is in relation to the coronary ostia. So with that in mind, say if you want to get access to the coronary artery, you can see that there is a post right there. So there is a commissure right in front of the left coronary artery. So it will be very difficult to put this catheter directly into the coronary artery. Even though it looks close, it is not exactly in the coronary artery. What would be the best way to enter the left main? You cannot enter from the front, because if you put this catheter in the front, it's impossible to wire backwards. But nothing is impossible, but it's difficult to wire backwards. On the other hand, if you put this catheter in this hole, then it is possible to go in the front easier. But again, to understand that this is the commissure, and that is the reason why it is going to be difficult. So ideally, you would try to turn this catheter posteriorly. Most commonly, it requires a clockwise rotation. Depends again, clockwise or counterclockwise, depending if it touches the aorta or not. But if it, let's say, it touches the aorta, then clockwise rotation will take you posteriorly, and you will be able to enter the coronary artery. So this is a very important part to understand in the coronaries. If you are if you look at the selective angiography literature for the SAPIEN valve, there are 2 ways people have divided this. One, to say that if you are at the ostial level, meaning the valve reaches the ostium, or the valve does not reach the ostium and it is infraostial. If it is infraostial, then obviously it is extremely easy. In most of the patients, you can do selective injection. If it is at the ostial level, depending on where the post is, it may be tricky. However, if you understand that how to go in which cell of the stent, then you can potentially do it in my opinion, more than 90% of patients, even though here it says that 8 out of 23, they could do the selective osteal engagement, 16 out of 23. So 5 patients they missed, which in my opinion is a little bit larger than I would have anticipated. Now, if you look at the core valve, now core valve is now what we use commonly is the Evolute Pro or Evolute R. And Evolute Pro, if you are going to use the Evolute Pro, the valve is very different in the sense that it has this post. Now, this is the marker for the commissure. So this is very important marker to understand. So if you see this, there is a marker that marks where the commissural post is. And then we are going to show you, I'm going to show you how to calculate that how far up is the cover. So there is a cover outside and these cells are covered. And as you can see, it is the node. So if you counted 1, 2, and 3 nodes, so 1, 2, and 3 nodes. So there, up to there, the bottom of the valve is covered. This thing extends up to 5. So if you measure 1, 2, 3, 4, 5, it extends up to 5 diamonds. So if you go up to 5 diamonds, there is a commissure in the Evolute Pro. Similar in the classic core valve also. However, the classic core valve, the top of the core valve is not as clearly delineated with this circular marker. Now, what is the importance of this circular marker? Because only one of them, so there are two markers. One is completely covered, the other one is open. The open one marks where the leaflet is. The closed one, it does not have the commissure. The open one, there is a little dot. So if you see the C, the fluoroscopic part of the C, if the C is like a C and not backwards, then this post is anterior. If this is like a D, then, or not like a D, but backwards C, then it is posterior. So this is very, very important information to keep in mind. And as I said, that you can have different valves with a slightly different 1 or 2 millimeter difference in the height of the cover, but the height of the cover is not that much different. So I already mentioned all these things, but I can go over this a little bit more in detail to say that if you are going to do the angiography, the first step is to do a aortography if you have any difficulty accessing the coronaries. I personally think that if the creatinine is okay, doing first a aortogram is very helpful. Personally, I like to do it in a biplane, or if an RAO and LAO projection is a good idea to do this angiogram. I'll go over it why it is important to do it in 2 planes. Now, if you look at this again, 2.5 diamonds is the ceiling skirt. So if you go up to 2.5 diamonds, up to there is the ceiling skirt, and up to 5 is potentially a commissural point. So the commissural highest point is 5, the lowest point is at 2.5. Very important to know. So here you can see this, that this is an aortogram. You can use, this is just right after the catheter valve deployment. And what you can see is that the valve is supraannular. So if the valve is placed high, which we try to do these days, so see this valve is placed fairly high. So if the valve is placed high, like this, then the transcatheter valve is going to be here. So if you count these diamonds, up to 5 diamonds will be the commissure. Similarly, if you look at in the LAO projection, you can identify the same thing. You will see that the valve is that high now compared to where it was before. So you can see now that the left coronary artery is just barely at the bottom of the new prostatic valve. So it is not possible to engage the coronary artery like how we normally do, coming down and then up. You're going to engage this coronary artery from the top. So this is a very important difference. So any of the catheter that forms in the sinus, non-coronary sinus, like AEBU or AL, is not a good idea, because you are never going to be able to put it like that, because you cannot go there. So the only way to engage this coronary artery would be from the top. So either a JL4 could work, or a shorter ampullars, AR1, AL1, something like that can go up there. So this is very important information to keep in mind. And again, 2.5 squares in the bottom are covered. So there is no way to come out of those 2.5 squares. Now, where is the marker? So you can see here there are two markers. So one is dark and one is open. See, the C of the open mark is facing the other way, meaning that the dot is here and the C is like this. So the C is facing leftwards. So it is not really a C, it is more like a D. If it's more like a D, then that commissure is in the back. So you can understand that this is in the front, this is in the back. And now, if it is in the back, you can count four links around to say where the other commissure is, and another 4 links around to say where the other commissure is. Now, or the other way to know is that this is not a commissure, 2 around is the commissure. So anyhow, if you count this to 4, you will know where, and you can see it in here too, that if this is in the back, this is the one that is the commissure. So the commissure is here. So if you want to access the left coronary artery 2 around, you will be able to come out of the sinus fairly easily. So again, this is posterior because it looks like this. It will be anterior if it looks like that. And here you can see that if you want to access the coronary artery, you can, if it's high, no problem at all, because the upper links are very large. There's no valve there. There's no commissure there. So this is a classic core valve. And in the classic core valve, you have this kind of links. So you cannot tell anterior or posterior. So which one is covered versus not covered is difficult to know in the classic core valve. But one of them is the commissure, the other one is not. So I'll come to that how can you determine in the classic core valve. So if you go 2 links around between the second and the third, there is no chance that it will be a commissure. So I'm sorry, I'll go back. So here, so this is the core valve. So this is, if you say that these 2 links exist on the top, then if you go 4 around, it will be covered. It can be a commissure if it is not itself a commissure. If it is the other way, is that if it's not itself a commissure, the 4 will be a commissure. So the third one between the 2 is unlikely to be a commissure. So this is the best way to understand where there is 100% a cell that is not covered is 3 around. And that's easy way to remember. And see, this is the right coronary artery. And you can see that the right coronary artery, again, many times it's easier to access the coronary artery from top rather than from the bottom in the prosthetic valves. So just keep that in mind too, that when you're going to access the coronary, it's going to be that high. And you see how high the valve is. So this is important to recognize that when you see the valve is that high. So even though you see the frame there, don't be misguided by the frame to say where the valve leaflets are. And many times it is good to organize. So this is a straight LAO view. So there is one in the back and this is the front. So remember this, that this is the front part of the valve. This is the back part of the valve. So you're looking backward like this, tilted. And so this is the reason why this one leaflet is that high, because it is not that it is measured from here to there. It is measured from this side to this side. And so that's why it is there. So sometimes it may be helpful to get the valve parallax out when you are going to do the angiography, but it's not absolutely necessary to get it out. Actually, sometimes it helps not to have the parallax to know what is the front and the back. So this is the topper part is the front part. This bottom part is the lower part, is the back part. The higher part is the front part. This is the back part. Now, the guide selection is also very important to understand. So if you are going to look at the guide to understand a little bit of the LAO and the RAO view of the coronary sinuses is important. So if you do the LAO view, you will see the left coronary sinus, the right coronary sinus, and the non-coronary sinus. And the left main will be there, the right is the other dot. If you look at the RAO view, you will see that the right coronary sinus in the front, the non-coronary sinus dependent one, a little bit in the back and lower, and the left coronary sinus right there underneath the left coronary artery. The left coronary artery many times is a little bit posterior rather than anterior in the left coronary cusp. So most of the time it is a little bit posterior in the left coronary cusp. So this is very important to recognize that where the arteries are in the LAO and the RAO projection. RAO projection particularly is important for the left coronary artery because you are going to decide that which cell to go through if the coronary arteries are covered by the stent. If it is not covered by the TAVR stent, then obviously it is easier to access. So here, one more time to understand that, as I mentioned to you before, that this is the commissure and this is the commissure. So if you're going to go inside of this coronary, you will go from the behind this and then enter. So you need a smaller catheter to form the curve, and you have a smaller distance here. So AR or GL35 would be a good choice. So if you're looking at the guide selection in the LAO view, it goes like this. In the RAO view, it will go like this. So this is a very important piece. So if you need a shorter GL, if you want to go a little bit further back because you don't have enough space to make a turn there. So a shorter GL sometimes helps if you are going to go more and more posterior, or a AL or even an AR catheter can be very helpful to go there. Now, if you want to select an EBU catheter or an XB catheter, impossible, because the TAVR valve is higher. So what happens is that because of the TAVR valve like that, there is no way, no sinus available to form the curve of the EBU, because the TAVR valve is here and the frame takes away the sinus. So same way, you cannot form a Amplatz catheter inside of the valve. So if you want to form the Amplatz catheter, you have to come from the top. You cannot come from the bottom like this. So this is also super important. So longer, in AL2-like catheter does not work. Shorter catheter, AL1-like catheter, or Amplatz right catheter works well for these purposes. So this is to summarize that if you start with the Judkins 4, that's not unreasonable. If you need to go more posteriorly, use Judkins 3.5. 4.5 is very rarely necessary. They target the frame cell that will be coaxial to the coronary ostia. Then always point it to the frame cell that is close to the coronary artery, most commonly posterior. Don't try to go anterior because it's difficult on the left side. And superior is better than inferior, because inferior cells, you cannot move the catheter up. So that is the first part. The second part is that when you are ready and you've done everything, let's say you use a guide extension or you use a guide catheter that's deeply engaged in the coronary arteries, do not just pull it, because you can pull out the valve. So it is important, if the valve is impossible to pull it out if it is a year or 2 years old, but if it is recently placed, meaning a few days ago, then it can pull out. So it is very important to keep that in mind, that you don't pull the guiding catheter. A lot of literature is available, again, dating from 15 till now, to say that how many times people could cross the valve, people could not cross the valve. Obviously, for the supracoronary valves, it can be tricky. However, all the valve types now has good guidelines and good understanding of the anatomy. So these numbers, although are very disappointing, that how many people could not cross the coronary arteries, this is not true. So you can fairly easily access the coronary arteries these days if you understand the anatomy, and if the coronaries were not too low in the self-expanding valves. Now, many people are taking care of this when they decide the valve type. These are some of the examples to say that when we can or cannot cross. So this is very easy. So if you have a valve and the coronary artery is that high, then you can just come from the top and be in the coronary artery. If the coronary artery is low or behind the commissure, you can see non-selective, but it's impossible to go inside. Not impossible again, but possible, but very difficult. And if you are below the valve, then obviously it is going to be extremely tricky to go inside of these coronaries. So you have to come out of the frame here and then try to wire like that. So you have to come there and then put some other catheter to come here, or a guide extension, and then try to wire. So there are different situations depending on where the coronary arteries are. Sometimes if the creatinine is normal, if it's elective cath, you can also do a CT angiogram to help you decide how to access the coronaries. There are several different types of valves. And again, you should learn all these different valves: the Gina valve, the Sapien XT, the core valve, Portico, the Accurate Neo. So the Accurate and the Sapien S3 are probably the easier valves to go to the coronary. Portico is also fairly easy. Jena valve is outstandingly easy. And the core valve is the one that can be tricky depending on how high the coronaries are and how high the valve is placed. So that is the first presentation. I wanted to now talk about a little bit about the coronary artery disease management in the patients with aortic stenosis, because it is very important that just not knowing the technical side, how to access the coronary arteries, it is also important to know when to treat the coronary artery disease, before, after, or not treat at all when the patients come with aortic stenosis. So first of all, how common is the coronary artery disease? So coronary artery disease is super common. So if you look at the concomitant CABG in the patients and for aortic stenosis, how many patients undergo concomitant CABG? If you are 70 years of age, it is almost 50% of the people undergo concomitant CABG. So it's not uncommon to have coronary artery disease. If you go above 80 years of age, then it's 65% of the people have concomitant CABG. So again, it is a very common problem. However, the symptoms of coronary artery disease are very difficult to evaluate in these patients, because if you look at these patients with the aortic stenosis, many of the patients, as you know, can have angina without coronary artery disease. And some of the people who have coronary artery disease may not have classic chest pain, but they may be short of breath, and it is difficult to tell whether it is angina or it is shortness of breath because of aortic stenosis. So the symptoms are a little bit tricky to analyze in these patients. However, if you look at the guidelines say that if you're going to send a patient for CABG, if you have more than 70% stenosis, patient should be bypassed. Now, makes sense. Do we have literature to support that? The literature is the opposite, as I'll show you. I would say that 2A is probably, because as you see the level of evidence is C, 2A indication may be a reasonable indication. So if you look at the operative mortality, why so? So if you look at the operative mortality with CABG versus CABG plus AVR, so AVR, no CABG, AVR, CABG. It is 2.5% typically for patients without CABG. And if you add CABG, it's twice as much, maybe 5%. So it does add some risk to doing CABG. And that is true in United States in hospital mortality. If you look at it, it appears to be as twice as much. However, if you look at the guidelines to say that what should we do for TAVR patients, it is very unclear. There is currently no very good consensus to say that what is the best way to treat coronary artery disease in TAVR patients. Now, I'm going to tell you my personal opinion in a few minutes, but it is important to recognize that if you are going to have surgery and if you need a coronary artery disease bypassed, the risk may be higher, but actually, if you adjust for the comorbidities, the risk is not that different. So if you take isolated, this is Cleveland Clinic data, if you take isolated AS, AVR, or AVR plus CABG, the outcomes are different. The AVR with CABG or AS with coronary artery disease patients do worse than without coronary artery disease, obviously, because they have coronary artery disease. But if you match the patient characteristics, then their outcomes are very similar. So in other words, it is the coronary artery disease, revascularized coronary artery disease does not add that much risk to the patient if the operation is successful and if you revascularize them. This is partner data. And again, you can see that in the partner data that if you have isolated AVR versus AVR and CABG, the mortalities are different, very similar to what I just showed you. And this is in all the patients undergoing partner in the partner 2A study. The only randomized trial where people with coronary artery disease underwent CABG or did not undergo CABG was done by Dr. Bono. And Dr. Bono did this randomized trial where he took the patients and they did not do bypass even though they had coronary artery disease. And they found that there was no difference in mortality. So the operative death was 5% in both groups, coronary artery disease or no coronary artery disease, only AVR was done. And if you look at their 5 years outcome, they're no different. Even if it's 1 vessel, 2 vessel, or 3 vessel, there were not that much of a difference in the people who had for the long-term survival. So does the coronary artery disease affect the TAVR outcomes? So there are several meta-analyses. This is one of the meta-analyses that one of our fellows did. And here you can find that 30 days, there is no difference. So cardiovascular mortality or myocardial infarction, no different earlier on. But as you follow the patients, there may be a difference. And this is typical for coronary artery disease, that if you take coronary artery disease over time, there is definitely a risk. However, the risk is not procedural risk. So we wrote a little review article to say that for the TAVR patients, we need to come up with a good guidelines to say that how the patient should be managed for coronary artery disease. There are several studies, small, looking at coronary artery disease management in the patients at the time of TAVR, meaning while you're doing the TAVR, and most of them suggest that it is safe. It does not add that much risk to the procedure. Now, how safe it is, some people are afraid that if you have coronary artery disease and aortic stenosis, is it okay to do PCI in these patients? And this is before the TAVR time, so 1998 to 2008, we took several patients who needed a PCI because they're symptomatic with coronary artery disease and had severe AS. And if you look at their outcomes, 30-day outcomes are no different than people matched population who does not have AS. So it can be safely done. However, the 1-year outcome are dependent whether they had at that time SAVR or not, meaning the aortic valve replacement or not. So what my point is saying is that if you're going to treat the coronary artery disease in patients with severe AS, you have to treat severe AS also. So you can treat it safely, but you need to treat the severe AS as soon as possible. Otherwise, it increases the risk. And once you treat the AS, their outcomes are similar to patients who did not have AS. Now, a couple of technical parts to the ostial stenting. So if you have this ostial coronary artery disease in patient, like this patient has an ostial right coronary artery disease. Now, when you're going to put a TAVR valve in this patient, what will happen is that if the stent is hanging out, it can be crushed. So what are the different ways to do it? One simpler way is to say that wire the coronary artery, do the TAVR, and then put a stent. So that probably is the easiest way to cover the ostium and not hang out the stent, or if it hangs out, does not matter because now you did the TAVR first. The second way is to use a very precise IVIS guidance or some other ways to place the stent accurately at the ostium and not hang out too much. Sometimes difficult to do that. The other third option is to use some kind of an ostial flare technology. So this is an ostial flare balloon. So you can use the ostial flare balloon to close to make the stent flat against the ostium. One last piece is that what happens when the left main coronary artery is too low. This is our 8th patient in Cleveland Clinic in 2005 or 6, something like that. So when we put the valve, you see here that the left main right there is going to be closed by this aortic leaflet with calcification. Nobody knew at that time what to do. This was the first case like this, and we found that the left main coronary artery is totally occluded, and we are doing CPR, as you can tell. So this time we poked with the stiff end of the wire, the back end of the wire, through the leaflet and tried to wire the coronary artery while putting the patient. At that time, our choice was tandem heart. So we put the patient on tandem heart, and then we did stent the coronary arteries. As you can see, with excellent result, patient actually did very well for 5 years following this intervention, discharged 4th day after the procedure. Now, if you look at then we tried to go back and say that let us understand that what happened. And we used to do CAT scans, but we never analyzed the CAT scans with this much clarity to say that this was small sinuses, there was large amount of calcium in the left coronary cusp, and the height of the coronary artery was less, and so it's like a perfect storm. And the post was right in front of the left main. So it was as bad as we can have in this particular patient, and that's why it closed. Subsequently, there are several studies to say that, if you are using balloon expandable valve, the coronaries are low, you have a risk of occlusion, and that risk can be 1% to maybe 2.5%. These days, we can predict this risk, and we can understand that which patients are at risk. So we measure the left coronary cusp, the distance, the height of the leaflet, and height of the coronary artery. Most commonly, the right coronary artery does not close because it is usually deeper in the sinus, and there is a right underneath the right cusp is the interventricular septum. So whenever you are going to put the right coronary artery is difficult to close with TAVR valve, except in patients with bicuspid aortic valve, where sometimes the leaflet length is very large in front of the right coronary artery. So this particular patient had a bicuspid aortic valve. We protected the left main because the left was closed, did not protect the right, and you can see that it almost closed the right. And then this is very tightly narrowed there. And then we could stent it, patient did well. There is a registry of TAVR valves where the left main was closed after TAVR, and you can see that the 30-day mortality was 41%. So it's not a trivial matter. It's very, very important to be able to predict this. If you have put the stent and intervention was done properly, then there was no risk of stent thrombosis of reintervention. These days, what we do, there are several different techniques, but if the leaflet is long and we are going to close the left main coronary artery, or at least we think that we are going to close the left main coronary artery, we would put a stent inside, wire it, and we typically use a guide extension inside of the guide. Why is important is because once you deploy the valve, and let's say you do not want to deploy the stent, then you can take it out easier without stripping the stent if you have a guide extension. So this is an important pearl to keep in mind. Keep the wire in the coronary, put the stent inside of the coronary. Just wiring the coronary is not enough. Sometimes I use, if the stent is going to go up to STJ, sometimes I use a balloon with the idea that once the stent is deployed, we will put another guide through this cell and put the stent straight rather than chimney the stent. So there are two ways to put the stent. One is to chimney the stent, or the other one is to put it straight. If you put a balloon here, you can balloon it so that at least the left main will not close. It will give you enough time to be able to wire the left main from the stent and then put a stent across. So these are all different ways. This particular patient, we did put a stent, as you can see there, because it was right. The leaflet was long enough, and that was the reason to put the stent. And again, you can put the stent right up to, so this is the stent, this is the leaflet. So if you, again, it depends. If you think that the leaflet is not going to close it, you don't need to put the stent. If you see here, the chimney stent is another way of doing this thing for the core valve. It is again, in my personal experience, it is easier to put the self-expanding valve than a balloon expanding valve than a self-expanding valve if the coronaries are going to close, because this is a supraannular valve. So keep that in mind. And the re-access of the coronary is also very important, as we mentioned. So if you're going to put a chimney stent with the low coronary, it may be tricky to access them in the future. But the steps are that you put a stent, you deploy the valve 80%, check if the coronaries are closed or not. If they're closed or likely to be closed, then go ahead and put the stent, then deploy the rest of the valve. If you want to do the post-dilation, then do a kissing post-dilation. And there are, again, the outcomes are available in relatively small series. This is 60 patients. So it's just to understand that the long-term risks are not well defined, but at least it does not seem to be a bad thing. And the last part is to do a basilica procedure, where we would say that we would go, so this particular patient, so sometimes we do balloon inflation, inject dye, and we find that the coronaries are going to be occluded. So this is one other way to determine that the coronaries will be occluded. So here what we do is we put the catheter right inside of the coronary cusp, typically the middle of the left coronary cusp or slightly posterior to the left coronary cusp. Then use the Estata wire, electrified, and come out. And then we collect and snare it in the snare. Here you can see we have snared the wire. And once you snare the wire, then you make a flying V. What it means is that you bend the wire in a tight curve, wipe off the coverings, and then electrify it while you're pulling it. So here we are pulling the wire. As you will see that we are pulling both these catheters. The wire is in between.
Yeah, I think so.
I'm sorry, my sound system is still working, but I'll turn it off. This is while we are doing this case. So that's why there was a sound. And so now we are deploying the valve. And when you deploy the valve, now the coronary, although covered, the leaflets are split. So you will not be able to see, you will be able to access the coronary through the leaflet. So see here, the valve is covering the coronary, but you can come out of the top cell. And then even though the leaflet is on both sides of the coronary, you can go through the split leaflet. Finally, I want to just end with one case to say that it is not easy to decide how you treat the coronary artery disease, but it is an individualized decision based on everything. So this is, for example, a retired neurosurgeon who came, who had a recent non-STEMI, who is now having stable angina. His creatinine is high, but he has severe AS, and the idea would be to do whether we should do the coronary artery intervention first, whether you want to do simultaneously or after. Now, very important, the first step to understand this patient is to, I will show you the coronary angiogram. So the coronary angiogram, so you can see that there's a tight circumflex lesion, there's a tight LAD lesion, and the patient is diabetic, so it's a long lesion, but they are relatively straightforward lesions to fix. And if you look at the right coronary artery, it also has a tight lesion in the right coronary artery, as you can see here. So this patient, of course, all focal lesions, nothing very complicated, doesn't need rotablation. There's some calcification, but you can see that the aortic valve is super calcified. Now, if you look at the aortic valve, it is very tight. The mean gradient is 47, the peak gradient is 86. And it's a thick ventricle with a tight valve. So you can see here, it's very tight valve. So how do we do this? So if the patient has heart failure and is the LV and diastolic pressure is increased, cardiac output is reduced, then it's not a good idea to do the PCI first. In those patients, it is better to do the TAVR first. If we are going to do just the TAVR and leave the coronary artery disease, at some point we have to intervene on the coronary artery disease. If the lesions are simple and if you're not going to use too much dye, then it's reasonable to stent them at the same time. Otherwise, it is best to do the TAVR first, let patient recuperate, and then do the stable coronary artery disease treatment. Coronary artery disease are unstable, then obviously you need to treat it simultaneously. So in this particular patient, we did the TAVR first. So you can see that the TAVR is done. And at the same time, same setting, since we had the coronary angiogram, we go ahead and stent his coronaries. And if you stent all the coronaries, as you can see here, all the coronaries we stented, the right, the LAD, circumflex, again, slightly longer stents in all the coronaries. And you can understand that all the this is done with a minimal dye. So this is very important to do it with minimum dye rather than using a lot of dye. So in summary, coronary artery disease is commonly encountered in AS patient. The presence or absence and the history of revascularization do not correlate with the worst procedural outcomes. So if you are just going to look at 30-day outcomes, they're no different. However, if you're going to look at long-term outcomes of the coronary artery disease, is similar to the long-term outcomes of any coronary artery disease. So what I tell people is that just treat coronary artery disease as if you are going to treat coronary artery disease without aortic stenosis. So if you think that the coronary artery disease is stable, you're going to medically manage it, then just do TAVR. If you are going to say that this coronary artery disease is unstable and requires intervention, then decide if the patient is in heart failure or not. And then if they are, do not do it at the same time. And if you're going to treat the coronary artery disease first because the patient is really unstable for the coronary disease, then do the aortic valve treatment sooner rather than later. PCI can be very safely performed in patients with AS. And I personally am not a big fan of using a lot of support devices and things like that, because with the same access that you need for support devices, you can put a valve. So if you are going to do something, might as well put a valve rather than try to do support device and things like that. And of course, the choice of stent most commonly is DES. We rarely use BMS these days. And the coronary artery access after TAVR is important for deciding what exact valve type you are going to use. So thank you for your attention. And I'll stop here.
Thank you so much, Dr. Kapadia. That was an excellent talk. There are a couple of questions from our audience here. Let me start with this one. Do you have any preference for access, femoral versus radial, in patients with core valve, with the evolute valve?
I myself like the radial access. I'm not a fan of femoral access, and I don't myself find any difference in the femoral or the radial access. If at all anything, the radial access is a little bit better than the femoral access, because especially for the right coronary artery, if you are going to use the left coronary artery, I think both of them are similar. Sometimes the left coronary artery for a very short aorta. So if the patient is very obese, ascending aorta is typically very short. In those short ascending aorta, you may have a little less maneuverability from the radial access. So either left radial access or femoral access may be helpful for those kind of patients.
Yeah, you actually answered the next question, which was any preference of right radial over left radial. So seems like left radial may be preferred in those short ascending routes. A couple of other questions in PCI. So what are your guides of choice for the common evolute or the sapien valves?
So most commonly, I like the AL1 or JL4 for the left system. If I'm going to use the JL guides, then I like guide extension. Both of them, I think the guide extension is useful. If it's evolute and a smaller evolute, then AR guides are also very helpful for the left system. For the right, again, JR4 is not unreasonable in many patients. I like personally the AR1, shorter AR guide, also for the right coronary artery. The Williams guide, or means ALR 1.2 or 3DRC guide are not good options, because they just don't have enough space in the root to touch the other side of the aorta.
Yes. One very important question is, how do you interpret stress test results in these patients with aortic stenosis and CAD?
So there is fair bit of literature now with the IFR, FFR about AS and coronary artery disease, and the literature is, if you synthesize it, it seems that it is not easy to be certain that this is really functionally significant coronary disease. So my personal bias is that if you have to decide by stress test whether the patient needs something, so this is like a stable coronary artery disease. So in this stable coronary artery disease, where if there is a question whether the patient needs revascularization or not, it is better to do it after the TAVR. Now, sometimes the call is different, because you are trying to decide between SAVR and TAVR based on how severe is the LAD stenosis, for example. There it is trickier, because there, if the LAD does not turn out to be hemodynamically significant by IFR, sometimes if there's a severe AS and if you relieve the AS, that lesion may become hemodynamically significant. So, and vice versa is also possible. So I think this is the part where a morphological stenosis criteria, meaning that using intravascular ultrasound, may be helpful to say that if it's less than 4 millimeters square, or if you use some kind of adjustment from the reference, that what is the lumen area would be a useful method of classifying it. I usually use 4 millimeters square cut point for 4 millimeter reference diameter, 3.5 millimeters square for 3.5. It turns out to be a good working number, although it does not make sense mathematically, but it is roughly true for those arteries.
Another very, very important question that we face is the use of mechanical support. If patients with these valves are presenting with shock, STEMI, would you use an impeller? Would you perform balloon? What mechanical support would you suggest depending on when the valve was placed, etc.?
I think that the impeller is probably the, if you already have TAVR, impeller probably is the safest device. If you have aortic stenosis and do not have the TAVR valve, again, I think doing a valvuloplasty followed by impeller is a reasonable choice. For typical aortic stenosis, contrary to what people believe, even intra-aortic balloon pump sometimes helps, especially in patients with coronary artery disease who are in shock. So if you want to have intermediate support, sometimes balloon pump can be helpful. ECMO or a device where you are going to empty the left ventricle and retrogradely perfuse the heart is not a great idea for aortic stenosis patients, because you can thrombose the roots. It is just not as effective as using impeller. So if I had to use something, I would do balloon valvuloplasty and use impeller. But again, in my mind, these days, you can just do TAVR safely in these patients.
Got it. And then is there a way to orient the evolute valve at the time of deployment to align the commissures away from the coronary ostia?
Yes, so there are some tricks that you can use to orient, that how the hat, again, I don't have a picture of that, but there is a way to put the hat in such a way facing the outer curvature so that when it comes out in a relatively, but again, everybody's coronaries are not exactly the same spot. So it is tricky. So it is not reproducible. Let's put it like that. So it is not reproducible that in every patient we can align it. Same with the sapien. So we have some tricks to align the sapien at the time of deployment. But again, it is not 100% reliable.
Thank you so much. That was a wonderful presentation and we really appreciate it. We could see the personal effort you've put in with all the slides, with your multicolor markings and everything. So thank you so much, and I will give it over to Dr. Ashwin.
Thank you very much.
Thank you very much, Samir. We all understand how busy you are, and we really appreciate you taking your time and your contribution to fellow education. We will be having a panel discussion at 12 to 12:30, if possible. If you could join, that's great. If not, we completely understand. But thank you very much. We really appreciate it.
Thank you.
I will move on to introduce our next speaker, Dr. Emmanouil Brilakis. Dr. Brilakis, after graduating from the Lycée Léonin in Patricia, Dr. Brilakis received his medical degree from the National Kapodistrian University of Athens, Greece. He trained in internal medicine, cardiovascular disease, and interventional cardiology at the Mayo Clinic. He also completed a master's in clinical research at the Mayo Clinic and a PhD in clinical research at the National Kapodistrian University of Athens, Greece. He served as director of the cardiac cath lab at the VA North Texas Healthcare System from 2004 to 2016, at which time he was also on the faculty of the UT Southwestern Medical School. Dr. Brilakis leads a large clinical trial group investigating treatment of chronic total occlusions, prevention and treatment of saphenous vein graft disease, prevention and management of complications, intracoronary imaging, antiplatelet treatment optimization, post-coronary stenting, radiation safety in the cath lab, and implementation of novel technologies in healthcare. Dr. Brilakis has authored or co-authored over 500 manuscripts and has written the Manual of CTO Interventions, now in its second edition. He directs the Complex Coronary Interventions webcast series, is a trustee of the Society of Cardiovascular Angiography and Interventions, and is on the board of Cardiovascular Innovations Foundation. He is an associate editor for Circulation, and he's on the editorial board member and reviewer for several journals and grant agencies. He has been lecturing and proctoring at several institutions in the United States and abroad, and he is going to be talking to us today about CTO PCI indications and gear. Thank you very much for doing this, Manos.
Thank you very much, Maki. That was it's a great privilege and an honor to be here this morning. And my talk is about CTO interventions and how to use the various gear, which actually is not just for CTO, although I will focus on the CTO, still the gear applies to every intervention, especially a complex intervention. So the first question I would like to address is whether you should do CTO PCI. And I think people are maybe familiar with many of those studies. We now have 5 randomized trials about CTO PCI, starting with the Euro CTO, Decision CTO, Impactor CTO, Explore, and Revask. And we'll go briefly over those trials. The Euro CTO randomized patients who had only a CTO, not multi-vessel disease, to either undergo CTO intervention or just medical therapy. And the primary endpoint was quality of life at 12 months. There was typical characteristics of those patients, about 18% had previous MI, and success was good. Looking at the quality of life at 1 year, patients who did have CTO PCI had better control of symptoms compared to those who did not. And actually, last TCT, about a year ago, Gerald Werner presented the 3-year follow-up showing that safety was about the same. The incidence of cardiovascular death and MI was about the same in the CTO PCI and the medical therapy group. So this study shows better quality of life control, but but no issue with higher safety, more events down the line. Looking at the second trial, which is the largest one published today, this is called the Decision CTO trial from Korea. This had a little over 800 patients. Those patients, in contrast to Euro CTO, many of them had also multivessel coronary artery disease, and they were randomized to either CTO intervention or no CTO intervention. There was good success rate, about 91%, and the primary endpoint of death, MI, stroke, or revascularization was the same in the 2 groups during a follow-up up to 4 years. However, there was several limitations from the study. One is that the patients had a lot of crossover. 1 of 5 patients randomized to medical therapy crossed over to CTO intervention. Their symptoms were mild, it was stopped prematurely, and the enrollment pace was slow. Also, when you have multivessel disease, there's a lot of controversy about what % or proportion of the patient's symptoms is due to the CTO itself versus the concomitant coronary artery disease. The third study, called the Impactor CTO study, that was a small randomized trial from Korea showing better exercise capacity if you go CTO PCI versus if you have medical therapy alone, which is consistent with other findings from registries showing better symptom relief and more exercise capacity in those who have recanalization of their CTO. And finish off with 2 trials that looked at the impact of CTO intervention on the ejection fraction. The first was the Explore trial that had an interesting design. It randomized patients who had a STEMI and a CTO to undergo PCI of the CTO within 1 week of the STEMI, or no PCI, but just medical therapy, with the primary endpoint being ejection fraction and LV and diastolic volume at 4 months. And there was no difference in those endpoints at 4 months. So no difference in the 2 groups. And similarly, the Revask trial randomized patients with CTO to CTO revascularization versus medical therapy. Once again, there was no difference in the ejection fraction or segmental wall thickening in the 2 groups. So the data from randomized trials is not as strong for improving ejection fraction. However, we also have multiple other non-randomized studies that have shown that if you have successful versus failed CTO PCI, which is of course an inherently biased comparison, but nevertheless, the outcomes in patients with successful procedures are much better than in those in whom procedures are failing. Observational studies have shown lower mortality during long-term follow-up. There are also some studies showing that patients with CTOs often have depression, and by recanalizing their CTO, their depression actually gets better. We also have studies showing that even if you have excellent collaterals, which is sometimes an argument, people say, well, if I have good collaterals, then why should I bother open the CTO? Well, it turns out that even with excellent collaterals, if you put a pressure wire before you put stents through the CTO, actually pretty much every single lesion has an FFR of 0.8 or less. And finally, we know that in patients who present with ST elevation myocardial infarction, if they have a CTO, then their early and late mortality is significantly higher than if they do not. The concept there being that you have already one territory being ischemic, therefore the impact of the culprit lesion is much more strong because you have ischemia to start with. And rarely we have patients like this one with refractory arrhythmias in whom coronary revascularization can actually help prevent recurrence of those arrhythmias. CTO is one of the main reasons for incomplete revascularization, and we do know that having complete revascularization on observational studies has been associated with better outcomes. Actually, the ischemia trial has some late-breaking events that will be coming out at TCT hopefully this year that will give some more light about whether complete versus incomplete revascularization improves outcomes. One important point that's especially for the boards is that the OAT trial, the open artery trial, actually was not a CTO study. This is now an old study, 14 years ago it was published. However, this was a study of patients who had an occlusion 3 to 28 post-infarctions in the infarct-related artery. So the OAT trial, as you know, was a negative trial, but it does not apply to CTO PCI because these were all acute ACS lesions. So the summary from all this, when should you do CTO PCI? I think there is acceptance currently that this is done for improving symptoms, which is very consistent with ischemia and in general for treating patients with stable coronary artery disease. Once again, the goal here is to improve symptoms in stable coronary disease. There is no significant difference in MI or mortality, at least in the group's studies so far. But to get these benefits, you're going to be successful, and success depends on the complexity of the lesion as well as the operator experience. And you want to have acceptable risks, both in the acute setting as well as in the chronic setting. And we do know that CTO PCI does have higher risk of complications compared with non-CTO PCI, as you might expect, since these are much more complex lesions. This was crystallized in a consensus document, global consensus document. The principal indication, again, is to improve symptoms for CTO PCI. However, for interventionalists, it does offer additional benefits. Doing these procedures makes you a better proceduralist. You learn to look at the angiograms better, understand the equipment, treat complex lesions, improve your workflow, manage complications, which are more common with CTO, be very careful with radiation and contrast, join a community of like-minded interventionalists who do complex procedures, and teaches you humility because even the best interventionalists will often fail in these complex procedures, understanding the value of preparation and taking a humble yet very sophisticated and very well-planned approach. The guidelines are a little outdated. I think the next version is coming out next year, but indication in the ACC and the ESC guidelines is 2A, level of evidence B. And this is for patients with appropriate indications and suitable anatomy. In summary, CTO PCI is done to improve symptoms. CTO PCI is a tool, like bypass is a tool, and it's part of the broader concept of coronary revascularization. So in patients who have previous coronary bypass, usually PCI is the way to go because the R2 bypass has high risk. Single vessel disease, again, PCI is the way to go. However, for multi-vessel complex disease, coronary bypass remains the standard of care, except in patients who are poor surgical candidates in whom PCI may be performed. So these are some of the thoughts about indications for CTO PCI, and I would happy to take any questions now if you prefer, or continue and have questions later on.
I think we should continue and then we'll have questions at the end, Dr. Brilakis.
Okay. Sounds perfect. So moving on to the equipment. Equipment is critical for all steps of percutaneous coronary intervention. And I like to break it down in 22 categories. And this applies to both CTO intervention, but also to non-CTO procedures. Starting with the seats, it is important to have good access that provides good support. we have seen an uptake of the radial approach for CTO PCI. Now, 2/3 of the cases that have, of CTO PCI cases involve at least one radial access, with the most common configuration being femoral and radial. You want to use, if radials are used, you want to use the thin-walled radial sheaths that allow larger guides to be placed in. And then sometimes in CTO PCI, it gets confusing because you need to have simultaneously in the same catheter a lot of equipment. So for example, you want to have a microcatheter and you want to have an IVUS catheter. And there is an app actually from an Italian group, from Mario Iannacone, Roberto Garbo, that's called Complex PCI Solutions. You can actually plug in what equipment you're using and tell you whether it's compatible with the guide you're planning to use. Also, if you want to use hemodynamic support, you do need larger size sheaths, 14, 15 for Impella and VA ECMO. Short sheaths are good. However, if there's any iliac tortuosity, it is better to use the longer sheaths, the ones that go, ideally, I personally use the 45 centimeter long, usually 8 French, that go all the way to the diaphragm. And those provide the straightening of the tortuosity of the iliac vessels and improve the guide manipulation and increase the guide support. And this is an example that standard sheaths reach to the internal iliac takeoff. The 25 go to the aortic bifurcation. The 45 go even higher to the diaphragm. Again, for radials, the thin-walled sheaths are the most commonly used, and 7 French, the 7 slenders, are the most commonly used as well. Sometimes for the left radial, why they use the snuff box, that's increasingly being used these days. Or alternatively, we can use a longer sheath and have the sheath protrude a little bit outside. And this way, it's easier to reach. You don't have to reach that far to get to the sheath and insert the guide. Promising outcomes from an Italian group showing a success of 90% in patients in whom distal radial access was used. There's still some issue with smaller patients and small size radial arteries, but in the vast majority, you can use distal radial for access. In terms of the guide catheters, there are many options, and the guides are not only for engaging and delivering balloons and stents, but also to monitor pressure and inject contrast. And in general, for complex PCI, including CTO PCI, we prefer to use the larger ones, the 7 and 8 French guide catheters. I strongly encourage actually our fellows to get familiar with these big guides because, especially if you do mainly transradial, you don't usually get exposed to 8 French. 8 French do provide strong support and make it easier to bail out in case a complication occurs. For CTO PCI, we often like to use shorter guide catheters, 90 centimeter, that makes wire externalization easier. If you don't have them pre-made, which is done now in the vast majority of cases, you can actually cut the guide, take a small sheath, 1 French smaller than the guide, cut a piece and use it as a connection to connect the pieces of the guide catheter. Side holes sometimes are used for the right coronary, but they should never be used in unprotected left mains because they can provide a false sense of security and they may mask ischemia that can lead to significant hemodynamic compromise if you compromise left main flow. In terms of the shapes, to put it simply, for the right, for complex, including CTO, we use amplats. AL1 is the most common. For the left main, we use EBU or XP. For left-sided grafts, AL. For right-sided grafts, multipurpose. And for internal mammary, IEM guides. The XB-EBU, again, is the preferred one, gives extra support, the same for the amplats guide for the right coronary artery. How about the third category, which is guide extensions? Once again, an essential tool. Many people cannot even imagine doing complex interventions without these tools. There are several of them currently available in the United States, and they're very useful for multiple steps. They can help with engaging the vessel, making the engagement coaxial, help with better selective angiogram, help with guide wire insertion, preparing the lesion, and delivering stents. So they can facilitate several steps of the procedure and come in sizes between 6 and 8 French. So equipment delivery can be facilitated. Here's an example of the balloon uncrossable algorithm. For CTOs and complex PCI in general, in my mind, it's critical to have a construct, an outline, an algorithm of what to do if a specific problem comes up during the case. So for example, if the wire goes through, but the balloons and microcatheters don't, you're going to have a set of steps you're going to follow to get this accomplished. And increasing support is a big part of this, and the guide catheter extension is a big part of having better support. This is an example of a guide extension. You can see it gets to intubate the vessel deeper, provides better support, and makes it more coaxial engagement. This is an example of a perforation in the middle AD during CTO PCI. It was very hard to deliver covered stents. However, after putting a guide extension, we were actually able to deliver the covered stent. So when things get tough, guide extensions can really make the difference for delivering equipment through challenging parts of coronary anatomy. This is another example, a perforation in a patient with recent bypass, couldn't deliver a covered stent, but by using a guide extension, the stent was easily delivered. And then they can also be used for thrombectomy. They can be used for retrieving equipment. This is an example of a rotablator that has been stuck inside the coronary artery. What was done is the rotablator shaft was cut, and then a guide extension was inserted over the entrapped segment, and then all the way down, and that helped actually provide extra support to pull the entrapped rotablator burr out of the coronary artery. When you do CTO intervention, the guide extensions can facilitate the reverse cart, which essentially means getting the guide wire, the retrograde guide wire, through the lesion in the subintimal plane and then into the undergrade true lumen. By having the guide extension, we do have a nice target for the retrograde guide wire to get back into the undergrade guide catheter. They facilitate undergrade dissection and reentry by limiting formation of hematoma in the subintimal space. And actually right now it's the current standard of care. If you're doing undergrade dissection reentry, in the vast majority of cases, it's best to use a guide extension to minimize hematoma formation. And then they can also be used to form a snare. There's an online video on this in which the guide extension together with a balloon and a standard 014 guide wire can be used to create a homemade snare for retrieving equipment or for catching the retrograde guide wire. And the snare can be adjusted by pulling or pulling the guide wire from the back part of the guide catheter. There are several tips and tricks for handling guide catheter extensions. The first one is to place the guide extension under a towel, because if you don't, one of the challenges is you can have wrapping of the guide extension with other guide wires, and that can not allow equipment to be delivered through the guide extension. So putting a towel should be the first thing you do after a guide extension is placed into the body. How to get the guide extension to the desired coronary segment. The so-called inch-warming technique is the preferred way to go, which means you get a small balloon, usually 2.0, halfway in, halfway out from the guide extension. You inflate the balloon, you deflate the balloon, and as you deflate it, you advance the guide extension that is centered and floats down the vessel. And this is an example of this. The balloon is inflated, balloon is deflated, and at the same time, the guide extension is advanced. So using this technique really makes it easier and less traumatic to the vessel delivering the guide catheter extension. Since the guide extension can be an issue for advancing equipment, do this under fluoroscopy. What can happen, especially if you put a smaller guide extension through a larger guide catheter, is for the wire to actually go outside of the guide extension. The guide extensions do have complications. Equipment deformation is one of them. If there's deep seating, they can cause dissection, thrombus formation. So it's important to keep that in mind when handling this equipment. Moving on to category number 4. This is about using support catheters. The most commonly used ones are the multi-cross and the center cross. And what they do is two things. One is they center the lumen, so the microcatheter is centered. And the second is through this nitinol mesh, they provide extra support against the wall of the vessel. Fifth category, Y connectors. You may think this is kind of a trivial category. However, we strongly encourage people not to use the rotating Y connectors. This is why. You can have a lot of blood loss in complex cases if you have to open close every time, especially CTOs. So using one of the automatic Y connectors can help reduce the amount of bleeding. Next category, which is critical for CTO PCI, is use of microcatheters, which is of course a Greek word. It is from mikros, which is small, and katheteros, which is the catheter. And these are critical devices for CTO intervention. Actually, it is one of the consensus statements that CTO PCI should always be done by using a microcatheter. And this is a classification I find useful, which is dividing them into 5 categories. The first one is big microcatheters that can usually be spun or rotated. The second is the smaller microcatheters. The third is the angulated ones. The fourth is the dual lumen. And the fifth one is the plug modification microcatheters. And these are several members from each group. This has actually been a very active area with several new devices being added in the last several months. But what is important is to have at least one device from each category in the lab which can facilitate the specific call. Now, what if you don't have a microcatheter? Can you use an over-the-wire balloon? And the answer is yes, but it's less optimal because in contrast to the microcatheter that has a radio-opaque tip, so you know exactly where you are, the small balloons, the 1.0 and 1.5, they have the marker in the middle, and therefore you don't really know where the tip is in relationship to that marker. So if you can use microcatheter, it's preferred, but if you not, at least use an over-the-wire balloon. The microcatheters help support the guide wire. You can remove it and change the tip. You can change the guide wire without losing the ground you've gained in wiring. Also, in retrograde PCI, they can protect the vessel from injury from the guide wire. Sometimes you can inject contrast through them to understand where you are or do the so-called Carlino technique. And finally, if you have a perforation, you can use the microcatheter to deliver coils and fat. This is why microcatheters are important. If you use a microcatheter, then the stiffness of the wire tip significantly, dramatically increases. Support of the microcatheter doesn't let the wire buckle and transmits much better the push from the back end to the front end. And as I mentioned, it's one of the standard principles. If you do CTO PCI, you should use a microcatheter to support your guide wire. These are some examples. These are big microcatheters like the Corsair, the Turnpike, the Mamba, and the Teleport. They provide strong support and they can be rotated. The microcatheters is actually a fairly detailed piece of engineering. It's not just a simple tube, but the wall has multiple braids. And what they do is that reinforce the wall and allow for rotation of the microcatheter. And actually, each microcatheter has a preferred direction of rotation. For example, for the Turnpike, it works best if it's turned clockwise. For the Corsair, it's the other way around. It works best if to be advanced if it's turned counterclockwise. And so turning the microcatheter is something very important to learn if you do CTO interventions. And sometimes rapid spinning is needed to get it through lesions. The second category are the small ones, like the Caravel, the Fine Cross, the Turnpike LP, Corsair XS, and Microcross. And those microcatheters are smaller in diameter, so they are easier to go through smaller vessels, especially small tortuous epicardial collaterals. Most cannot be spun, even though the Turnpike LP and the Corsair XS can actually be rotated. The third one are the angulated microcatheters, the Venture, Swift Ninja, and Supercross. Very important for treating ostial circumflex CTOs and wiring through areas of tortuosity. The fourth one are the dual lumen that can allow wiring next to an existing wire or parallel wiring technique. And there are multiple categories. Both the Sasuke and the Twin Pass are currently available in the United States. And this is an example of parallel wiring. The one wire stabilizes the microcatheter, and the second wire is used to penetrate the CTO. And finally, there are microcatheters like the Tornus and the Turnpike Gold, which are designed to actually modify the lesion. This is like a screw going into the lesion that can help cross those very tough balloon uncrossable lesions. So that was briefly about microcatheters. And moving on to guide wires, which is probably the category with the most options and the most confusion. There are several types of 0.014 wires. Also, there are larger wires for delivering guides to the vessel. And this is a classification I personally find useful of thinking about guide wires. The first category are the workhorse wires, which are the ones we use in everyday routine PCI. And those typically have a soft distal tip. They can be made of stainless steel or nitinol. They have some of them have advanced construction techniques, but they are easy to advance. They are safer wires because they are less likely to perforate. And they're the one used in most standard PCI. Also, these are the ones that should be used after we cross with a more aggressive wire, the CTO, because otherwise standing over these wires can actually lead to distal perforation or dissection or other problems. So workhorse wires is the way to go. Some of them have hydrophilic coating, some do not. It is important to know which ones do and which ones do not. The second category are the so-called polymer jacketed wires. And there are three subcategories of these wires we'll discuss in a second, but those wires are very commonly used in CTO PCI, but they're also commonly used, the soft non-tapered ones, for wiring through tortuosity or other complex wiring. The third major category are the stiff tip wires. And those are usually mainly in CTO PCI. And their goal is to penetrate through calcified and resistant lesions. Fourth category are supportive guide wires that are designed to facilitate delivery after you cross. Then we have atherectomy wires, externalization wires if you go retrograde, and the pressure wire for performing physiologic assessment. Again, workhorse are going to be the wires you use for the vast majority of PCIs and the ones you stent on, and there is a lot of variety. Everyone has their own preference on this. The SUO3 is one wire worth mentioning. It is the softest wire available with 0.3 gram tip and has a hydrophilic coating. This is actually becoming the wire of choice for wiring through epicardial collaterals and even septal tortuous collaterals as well. So very soft, very traumatic wire that can be used in a variety of situations. Some wires like the Xeon do have a special construction, and that helps with transmitting the torque from the back end to the front end. When it comes to the polymer jacketed wires, there are the soft non-taper, like the Fielder FC, Pilot 50, Whisper, and Choice PT. Again, the Xeon Black. These are used quite often in the setting of tortuosity. The soft taper ones are the most commonly used initial guide wires for crossing a CTO. And there are stiffer ones like the Pilot 200, the Mongo, and the Raider, which are also commonly used in CTO. And these are some examples of the polymer jacketed wires. The soft taper wires, the Fielder XT, is again one of the most commonly initially used guide wires. The Pilot remains fairly commonly used for crossing through CTOs, especially if the course of the vessel is not well understood. When it comes to the stiff wires, we want to separate them into those that have moderate stiffness, like the Gaia, the Judo series, and the Ultimate Bros. And those wires are tapered. They have between 1.7 and 4.5 grams tip. So they're stiff, but not super stiff like the Confianzas. And the stiff wires, Pro 12, Hornet, Persuader, Astado 20, these are very stiff wires that are mainly used when there is tremendous resistance at the proximal cap to wire through areas of calcification. And these are the examples of the Confianza wire. This is a common algorithm. Again, there's a lot of variability and a lot of personal preference, but most operators start crossing a CTO with a polymer taper tip wire. And then if the course of the vessel is understood, then Gaia, and Gaia second is the most commonly used second one. Otherwise, if the course is not entirely clear, a Pilot 200 or similar polymer jacket stiff is used. And if the cap is heavily calcified, the Confianza Pro or the Hornet are the most commonly used. The support wires are used to deliver, especially through areas of tortuosity. A special case is the wiggle wire that has all these curves that help deliver equipment within previously placed stents. Each atherectomy modality, rotational and orbital, has its own guide wire that needs to be used for performing this modality. And then if you externalize, there is the R350 and RG3 designed specifically for being externalized. That was about wires, and now we'll move about balloons. There are 8 categories of balloons that we'll discuss in a second. The standard balloons we use are the compliant and the non-compliant. The non-compliant are the most commonly ones used for post-dilatation of stents. But there are several specialty balloons, including small balloons, balloons to modify the plaque, balloons for trapping, the ostial flask balloon, drug-coated balloons not available for coronary in the US quite yet, and then very high pressure balloons, and now also the not approved yet, but about to be approved intracoronary lithotripsy guide wire balloon. And those become important when treating the balloon undilatable lesions. This is a similar algorithm with a balloon uncrossable, showing the different options if you have a lesion that the balloons cannot expand. There are multiple small balloons available. In the US, the smallest one is the Sapphire Pro, that is 1.0 millimeters. And again, this is one of the first choices when you have the balloon uncrossable lesion. There are the special balloons to modify plaque, like the angiosculpt, the cutting balloon, and the chocolate. There is a trapping balloon that can be used for changing equipment when short guide wires are used. These balloons can trap the guide wire stays in place, and then the microcatheters are being removed. The ostial flask is a specifically designed balloon to flare the ostium of stents placed in an ortho-ostial location. So instead of having the stent stick out, what this balloon does is it flares it and makes it more opposed to the ostium of the vessel. And then another balloon not yet available in the US can go up to 30, 40 atmospheres, and that can help expand these underexpandable lesions. And finally, the intravascular lithotripsy balloon emits these lithotripsy waves that can help with expansion of heavily calcified lesions. Category number 10 is about atherectomy, and there are 2 modalities, orbital and rotational. They're both very useful, I think very important for treating calcified lesions that are fairly common in CTO PCI. Laser is another very useful modality, especially for balloon uncrossable lesions. It can also be used together with contrast in balloon undilatable lesions. The downside is it takes 5 minutes to warm up to be ready, and also it's fairly heavy and hard to move inside the cath lab. Moving on to other equipment categories, the ones relevant to CTO is the dissection reentry equipment. And this is the crossboss and the Stingray. The crossboss is designed to cross subintimally and is currently used mainly for in-stented CTOs, whereas the Stingray balloon is used for reentering if the guide wire gets subintimal into the true lumen. Intravascular imaging is another key category. For CTOs, IVUS is mainly used for crossing to minimize dissections. There are many types of IVUS, but the one most commonly used for CTO PCI is the phased array eagle eye that also comes in a short tip variety that can get close to the tip and help visualize the proximal cap. And this is an example. This is a CTO. The IVUS is placed in a side branch, and then by visualizing the proximal cap can help determine the location of the wires. Expanding the stent is key for CTO PCI, and there are actually studies showing that if you expand the stent, you have less incidence of MACE during 1 year of follow-up. This is the largest IVUS CTO trial. Equipment category 18 is about complication management. That's critical for CTO, but for any PCI, because complications can happen at any time. And they consist of covered stents, coils, also you can use vascular plugs, pericardial disease kit, and various snares. We do now have 2 covered stents, the Papyrus and the Graftmaster. Papyrus is lower profile and easier to deliver. There are multiple kinds of coils. we recommend having in the cath lab a 0.014-inch coil, because this can be delivered through any microcatheter, whereas the larger ones require a larger microcatheter. The Unplugs vascular plugs are commonly used to close vein grafts or larger vessels, and they're useful in retrograde CTO recanalization after recanalizing the native coronary artery. Pericardial synthesis makes things easy. You don't have to have one. You can use a standard needle and pigtail catheter, but having this makes things faster and easier. And finally, snares are important, not only for snaring the retrograde wire in retrograde CTO PCI, but also for snaring equipment in case equipment is being lost. And if you don't have a pre-made commercial snares like the Ensnare, you can make your own, putting the wire through a catheter and pulling it back, or using the guide extension as we discussed earlier on. There are also some smaller ones that can be used inside the coronary artery. Category number 19 is about radiation protection, very critical for CTO PCI complex PCI. There's various disposable pads like the RAD pad, and now there's more equipment like the zero gravity, other options for reducing operator radiation exposure. When it comes to hemodynamic support, several options. The most commonly used one is Impella CP for CTO PCI. There are rare cases in which the patient is at critical risk in which VECMO may be used, but again, in most cases, Impella is the one most commonly used. Contrast management. Actually, contrast is becoming the limiting factor in many CTO PCIs as the new machines, the new X-ray machines make radiation doses lower. So being very attentive to contrast, using intravascular imaging, potential some contrast saving devices can help minimize the risk of contrast nephropathy. And then finally, brachytherapy is actually available in many centers and remains the modality of choice in the US without drug-coated balloons to treat recurrent refractory in-stent restenosis. So a couple of things about CTOs, PCI, and complex PCI in general. You want to keep your table organized because you will see very soon things can get out of control, and having someone keep the wires and the microcatheters and the balloons and the stents in order can be critical for keeping the case moving smoothly and not having to open a lot of additional equipment. Also, having the equipment in a dedicated CTO PCI cart can actually help with getting the equipment faster to the operator, which reduces the time of the case and makes everyone more successful and happier doing those cases. But we shouldn't forget that, like everything else, the most important equipment is the brain, is how we use what the options that we currently have available in the cath lab. So I'm going to stop here. Again, thank you so much for the opportunity to talk. I know it's a vast topic talking about equipment, but I'm going to stop here and welcome any questions.
You covered a lot of important information in a very short time, and you did it very nicely, Dr. Brilakis. So let me start off with a couple of questions, and I'm sure the fellows will have more. So is there any difference in the DAPT duration or the DAPT therapy you would use in particularly the CTO patients?
That's a great question. There are some retrospective studies that suggest that prolonged DAPT may be beneficial in those patients. And part of the reason is you often have very long length stent, 60, 80, 100 millimeters of stent. So in patients who do not have high bleeding risk, most operators would favor a longer duration of DAPT, longer than 12 months. But again, that's individualized based on the patient's risk of baseline risk of bleeding.
So this question of native CTO PCI versus the SVG graft PCI. Could you comment a little bit on that? And what would you do if you did open the native vessel with the graft?
Yeah, absolutely. This is a great point. This remains an area of controversy. Actually, some CTO operators are saying that they never do PCI of vein grafts anymore because we do know that vein grafts do have poor patency long-term, and also they have high risk of peri-procedural complications during the case itself. At the same time, doing CTO PCI in bypass patients is not always easy Sometimes it's hard to go retrograde. There is often a lot of calcification, a lot of tortuosity. So this is something that has to be individualized. But in many cases, especially when the vein graft completely occludes, many operators will do what's called the stage revascularization. You would first open the vein graft so you minimize the acute injury in a patient with ACS, and then bring the patient back in a few weeks to open the vein graft, often using the bypass graft as the retrograde conduit. There's actually a trial, a randomized trial going on in Europe with Paul Kanapen that is randomizing patients who come with vein graft lesions to either undergo PCI of the vein graft or the native corresponding coronary vessel instead. And I think that would be a very good study to better understand what is happening. But this remains an area of controversy. I think most operators, if they can recanalize the native, they would prefer it on the long run.
So we see a lot of CTOs on a daily basis. When should we be referring these patients to a CTO operator?
Yeah, that's a great question. And I didn't talk about this, but it is well known that the success rate of CTO intervention is directly proportional to the operator experience and expertise. So higher volume operators are more likely to have successful results, especially for the more complex CTOs. So it all depends on the local level of experience and comfort with various lesions. If some operators are, for example, comfortable only doing undergrade approach or undergrade and undergrade dissection and reentry. So in these centers that only do undergrade, if there is a very complex CTO, for example, a JCTO score, which is a level of complexity, a measure of complexity, 3 or 4 or 5, it may be best to refer those patients to a more experienced center because there's a good chance that they may require retrograde crossing or some other advanced crossing technique. At the same time, if the operator is well-trained and has a good understanding, people can actually try to recanalize the undergrade, and if it doesn't work, then refer the patient later on. So again, it's highly individualized how to approach those patients, but it all depends on the local expertise.
Got it. Another quick question, good question was for people who are starting out of CTO training or starting a CTO program, what are your what would be your input or guidance?
Yes, absolutely. And this is another great question. The pathway for becoming a CTO operator is not as clear, to put it in this way. For example, like the structural, there are some advanced training programs. I mean, we've had a few advanced training fellows, CTO fellows in the past, and there are many programs, New York, Henry Ford. There are some very good programs that can train you. But I think the majority of people who become CTO operators, what happens is they go to practice, and they practice for a few years, couple of 3 years, at which time they build their skills. Because the challenge here is these are very complex lesions and require a baseline good understanding of equipment and techniques. And then after those couple of years, then they have a proctor come in and start doing CTOs and then gradually expand their capacity and do more and more complex lesions. So I think that route, which is on the job training with some proctoring, participating in courses, there's a lot of books, online resources, is the most common one. But again, in people who have the time and the opportunity to do a dedicated CTO fellowship, that obviously expedite things and makes things easier in the long run. But again, both ways are appropriate. It depends on everyone's time and opportunities that come up at this specific period of time. The one thing that I want to emphasize is that this area remains in a lot of need for more operators. For various reasons, including difficulty, stress, there are not enough operators to do CTOs and complex PCI in general. So my advice to early career people or fellows in training is that this is a great area. It's not an easy one. It's going to be a difficult one. But unlike, for example, structural, that now there's some level of saturation happening, there is a lot of still of demand for complex PCI operators. So in the long run, this is an excellent career choice.
Great. We have a question from Dr. Saurabh Joshi who wants to know, along with convincing symptoms and angina, do you need non-invasive stress test or as well as AUC, as well as to meet AUC before you do the CTO PCI?
Yeah, excellent question. Actually, an interesting point for AUC is that the original version of AUC, they did have specific recommendations pertaining to CTO. However, the second version removed the CTO as a separate subgroup. So it treats the CTOs as just part of the standard stable ischemic disease patients. Now, the answer to the question is it depends. In patients who have convincing symptoms, angina, and they don't have other issues, for example, if a patient has severe symptoms but has multivessel disease, it's hard to know, okay, is it the CTO, is it the non-CTO, etc. But if CTO is the only lesion and the patient has class 3 angina on optimal medical therapy, I don't think you need any other test, non-invasive or otherwise, for the indication. I mean, quite often we will do a CT if it's complex to help plan the procedure, but this is not for determining the appropriateness, but it's more so for optimizing the likelihood of success. So if you have severe symptoms, medically refractory, which is similar for non-CTOs in other patients as well, then I think that's a convincing indication. However, in patients who have either unclear symptoms, for example, they have dyspnea, which quite often is the presenting symptom, especially in older patients, or in ones who have a more complex picture, for example, low ejection fraction and dyspnea and some angina, then doing stress testing or some sort of ischemia assessment can be useful for determining the appropriateness. Also, for patients who have CTOs and they often say that they're doing okay, but their spouse or significant other says that, hey, but it's not doing quite the same. So putting them on a treadmill can help determine, are the patients actually limited by their symptoms or not? Because the slow progression of disease, sometimes people get adjusted to those symptoms and they don't feel that they're limited, although in reality they are.
So that brings us to the question, how long do you wait after giving them with the medical therapy? Should we wait 3 months, more than that? What do you usually do in your practice?
Good question. I don't think there's a specific time limit. For me, you're going to see this fairly quickly in the first week or two. So in our practice, we give it for 1-2 weeks, see if there is any improvement. If there isn't, then we either escalate or change the medical therapy or proceed with intervention. So I don't think you need to wait for 3 months. Sometimes this can be a cruel, unnecessary punishment. I mean, if the patient's having clear symptoms and don't get better, I'm not sure we need to wait for a long period of time to prove that actually they're refractory to medical therapy.
So we have a question from Dr. Shaif Gabasha, who says, there's some data from the Syntax trial that shows complete revasc in the PCI arm with multivessel disease have similar outcomes to CABG patients. And given the advancements in the PCI technology over the past decade and this hypothesis generating data, do you foresee any utility of another major PCI versus CABG trial in multivessel disease?
Yeah, again, excellent question. And we absolutely love to have such a study. But the challenges that are going to be by the time, first of all, funding these days is extremely challenging. We try to do some CTO trials and funding is extremely limited. But assuming that the funding issues and the practical issues are resolved and we have the green light to start a study like this, even if it starts today, we're talking about a process of 5 to 10 years to actually get results. And by then, I think we'll still be in a different pace, a different place with different stents, different techniques, different success rates. So yes, it would be wonderful to have it. However, I'm highly doubtful that it's going to happen, at least in the foreseeable future.
Excellent. So for patients who have multiple CTOs, Dr. Brilakis, how do you decide which one to open first? Do you have heart team discussions, or there was a recent paper too by from Boston. Can you touch on that a little bit on how you decide which one to open, how do you plan for these, and which teams are involved?
Sure, absolutely. I think you're referring to Farouk Jaffer's paper about the heart team, which is an excellent, it's an excellent overview. And actually we're using his checklist sometimes in our place as well. I do believe for many of the CTO patients, a heart team is essential, especially the ones who have a complex disease. The ones that are less, there's less need for that is the ones who have previous bypass. And I think in the US, about 30 to 50% of patients who have CTOs and are referred for CTO intervention actually have previous bypass. And for many of those, it's pretty clear cut that second bypass is either not a good option or the patient itself, himself or herself, does not want to have it. But the ones who have a no previous coronary vascularization, I think it's important to have a discussion. If it's a single vessel disease, for example, an RCA CTO, I think most people would agree that there is no need, because most of those, you should try PCI first. You wouldn't do bypass for a single vessel RCA lesion. However, the ones who have multi-vessel disease, I think that's the right thing to do. And in general, ad hoc CTO PCI is not a good idea. I mean, we rarely do it in patients for logistical reasons, but CTO PCI is ideally done as a separate procedure. Diagnostic is done first. Then there is enough time to discuss with the patient, discuss with the family, make sure everyone's on the same page. The surgeons talk to the patient. So before we actually go and do something, everyone is in agreement that what we're planning to do is what is the best thing for the patient. And that applies especially so if you have other comorbidities or if you have other vessel disease. Now, to the first part of the question about the sequence of doing CTO PCI, let's say you have an LAD CTO and an RCA CTO. Which one do you do first? And that depends. In general, the first one is the one that is safer. So for example, if you have an LAD CTO, but to recanalize that, you have to go through a complex epicardial collateral versus a more straightforward RCA CTO, then in most cases we'll do the simpler one and safer one first, and then stage and do the second procedure at the second time. And in general, we don't like to do two CTOs in one case, except if things really go extremely smooth in one case. I mean, we did have a patient recently with left main CTO and de novo without previous bypass that were able to open both the LAD in the circ in the same setting. But for most cases, it's best to stage, if you have two CTOs, fix one now, let the patient go home, come back in a few weeks and work on the other CTO later on. And sometimes actually opening one CTO in those patients with previous bypass, other comorbidities, may be all they need for symptom improvement. Then they come back and the symptoms are completely controlled, in which case you may not always need to tackle the second lesion as well.
Awesome. Thank you so much for joining us in that wonderful presentation and answering all those questions, Dr. Brilakis. Over to Dr. Ashwin.
Thank you, Poonam. Thank you very much, Manos. That was an excellent talk, very well received. And again, we know how busy we are, so really appreciate you doing this and contributing to the fellows' education. We will be having a panel discussion in about an hour or so, and I can send you a reminder if you could join us. That would be really great. Thank you.
Absolutely. Thank you.
Thank you. I'm going to move on to our next speaker at this time, Dr. Ankur Kalra. Dr. Ankur Kalra, we were supposed to have had a different speaker, Dr. Eric Yang from the Mayo Clinic, but there was some unexpected emergency and Ankur stepped up at the last minute and he's doing this talk on pharmacology for us. So we really appreciate his flexibility and being able to do it at the last minute. Dr. Kalra is an interventional cardiologist at the Cleveland Clinic. He is the section head of cardiovascular research at the Cleveland Clinic Akron General Hospital. And he's also the director of the Barry J. Maran Hypertrophic Cardiomyopathy Center in New Delhi, India. He's also the editor-in-chief of the Radcliffe Cardiology's U.S. Cardiology Review, a peer-reviewed cardiology journal, and host of the cardiology pod show, Parallax. He has presented late-breaking science at national and international scientific cardiovascular meetings and has published over 200 scientific manuscripts in various peer-reviewed journals. He has done his education at Indira Gandhi Medical College in Shimla, India, and then he completed medical and cardiology training at the All India Institute of Medical Sciences in New Delhi, India, Cooper University Hospital, Camden, New Jersey, and Hennepin County Medical Center and Minneapolis Heart Institute in Minneapolis, Minnesota. He also served as a clinical and research fellow at Beth Israel Deaconess Medical Center and at Harvard Medical School. He's done his interventional and structural fellowship at Houston, Texas. In addition to his interests in cardiology, he's also certified in patient safety, healthcare quality, health informatics, and leadership from Harvard Med School, and is currently pursuing a Master of Science program in health economics, outcomes, and management in cardiovascular sciences at the London School of Economics and Political Science in London, UK. He is also the author of the poetry book, Ibada, and he's going to be talking today about cath lab pharmacology to us. Over to Dr. Kalra.
Yeah, well, thanks for the very kind introduction, and also thank you for the invitation. It's an honor and a privilege to present this talk with the audience today. I have shared my slide set, and I think Shubhadeep was supposed to put it up.
Yes, I'm just gonna do the slideshow.
Yeah, and then if you could just help me advance the slides when I just say next slide, then that'll be
absolutely.
All right, so, well, thanks again to Poonam and to the organizers for the Interventional Board Review. This was sort of, last minute as everyone has learned, and I can't thank my mentor, Dr. Bhatt, for his permission to share his slide set. This is from a talk that he gave at the Fellows course for Cardiovascular Research Foundation. Next slide, please. So this is, just an acknowledgement to Dr. Bhatt. So I'm going to start with, yeah, you can go to the next slide. Thank you. So I'm going to start with, some basic concepts on thrombus formation. And, just before we begin and go through the entire slide set, I think it's important for me to reiterate, having taken the interventional boards, I think took them 2016, so about 4 years ago. Pharmacology actually is a factual topic. So, there are a lot of nuances and iterations to how we do PCI, and, you and I can have different wire selection and different catheter selection. And I don't think that's testable. That's what even Dr. Bhatt has stated in his talks. But pharmacology is a topic which is very factual. So, for those of us who make board questions, it's a very easy topic because, it's all facts. So I think, when you're preparing for your boards, I think it's important to spend time on this topic. So with that, we know that platelet aggregation is an important pathophysiological mechanism for thrombus formation. And sort of what happens is the platelets attach to the endothelial lining, as you can see in the top row, and then they conform into a different shape, release thromboxane A2 and adenosine diphosphate and fibrinogen, among other mediators of thrombogenesis. And the next thing you know, there's aggregation. And that's where pharmacology that is relevant to interventionalists starts coming into play. So you have the glycoprotein 2B3A receptor, which is important for the newly conformed platelets to stick to one another. And then you also have stabilization of clot and clot retraction. And that's where fibrinogen and fibrin or thrombin come into play. So keep that in mind, particular, from this figure for the boards, I would say the second row, which deals with platelet aggregation, you're going to get tested on glycoprotein 2B3A receptors, their pharmacology, and also glycoprotein 1B and 9B receptor and its pharmacology. Okay, next slide. So I think it's an important slide. I haven't really focused much on aspirin because I think aspirin use is ubiquitous in the cath labs. But I think it's an important concept, at least, based on this slide, and that is the use of enteric-coated aspirin. Now, this was a neat pharmacokinetic pharmacodynamic paper that was published in the Journal of the American College of Cardiology in 2017. And what this paper showed was, so this is not a clinical study, so it didn't really look at clinical endpoints or hard endpoints. What it looked at was some of the pharmacodynamic properties of enteric-coated aspirin. As you can see, plasma levels of acetylsalicylic acid on the y-axis, and then you've got time of onset on the x-axis. And what you see was that the number of non-responders were significantly higher compared with the number of responders, as you can see for aspirin. So, I'm not even sure if, simply uncoded aspirin is available anymore. At least when, all of us use electronic health records or electronic medical records nowadays. And I don't really see that as an option anymore in the drop-down menu in our hospitals. But, I'm fairly confident that emergency departments and cath labs across the country do have just plain aspirin. But keep that in mind. I think the value of plain aspirin is very important when doing PCI. All right, next slide. Okay, so, this is, somewhat of a historic data, but I think from a board perspective, again, important to keep these studies in mind. I think one of the questions that you're going to get tested is 100%, testable question is, you'll be given a scenario where a patient came in with ST elevation MI, happened to be a diabetic. The interventionalist decided to use a 2B3 antagonist. And the next day, there is a precipitous drop in platelet count, and then they're going to give you options of different, 2B3 antagonists. So the three that have been studied the most, or actually I should say two in the setting of ST elevation MI, are eptifibatide and ipsiximab. So, this is a slide which looks at data from the ipsiximab trials. And what you see here is, particularly in diabetics, there was a signal for benefit. There was a reduction in mortality when ipsiximab was utilized compared with placebo. So if you look at the curves which are in red and in green, and red and in green, yeah. So the red and the green curves are the ipsiximab curves, and then the yellow and the pink are the placebo curves. And what you see is that there is a reduction in all-cause mortality when at 1 year when patients who were diabetics were administered ipsiximab. I do see a question pop up in my chat box, so I'm going to get to all these questions at the end of the talk. I just want to focus on the topic of discussion, but keep your questions coming. I'm sure this is going to be an interactive session, so I do want to answer as many questions as I'm able. Okay, so keep that in mind. I think so the take-home message for the boards from this slide is ipsiximab. Important 2B3 antagonists of historical importance, leads to a precipitous drop in platelet count, so thrombocytopenia, so keep that question stem in mind. And there is a particular benefit when it comes to mortality in diabetics. Okay, next slide. Okay, so again, these are now data comparing the two 2B3 antagonists, with placebo. So on the left is ipsiximab, and as you can see, there was a more pronounced benefit for the drug in diabetics compared with non-diabetics, and sort of a similar trend at 1 year for mortality for eptifibatide. Okay, next slide, please. Okay, so this is a meta-analysis which basically looked at 2B3 inhibitors. Now, this is not in the setting of ST elevation MI. Remember, the very first slide that I showed you was in the setting of STEMI. This is in the setting of non-ST elevation acute coronary syndrome. And these are, as you can see, odds ratios with 95% confidence intervals. And the take-home message from this slide is these are diabetic patients who were admitted to the hospital with non-ST elevation MI. And what the manuscript demonstrated was that, again, of historical importance, I'm not sure in the modern cath labs 2B3 antagonists are used that often, but this is when we didn't have that potent of ADP receptor antagonists as we do now, and I'm going to go over them in my subsequent slides. But 2B3 antagonists fared better compared with placebo in diabetics who presented with non-STEMI in the cath labs. That's the very last row of this slide. Okay, next slide, please. Okay, so the conclusion was that in diabetics, go back. I just wanna reiterate the conclusion here. Can you go back one slide? Okay, great. Yeah, so in diabetic patients, about 1,200 undergoing PCI during index hospitalization, use of glycoprotein inhibitors was associated with a mortality reduction at 30 days. This is from 4% to 1.2%. As you can see, the odds ratio is 0.3. Tight confidence interval number needed to treat was 36. Okay, moving along. So next slide. So now I'm going to start talking about the ADP receptors and then the ADP receptor antagonists. You know, there will be, the reason I think even Dr. Bhatt put this slide up and, you know, I sort of left that slide in the talk for today was, you know, you are going to get tested, and, you know, I don't know if I should call it fortunately or unfortunately, because, you know, none of us actually find any practical use of this information, but I think again is important for you know, preparation of board review and for the test takers, is you're going to get tested on pathways through which the ADP receptors work, believe it or not. So I think it's, if you can take a snapshot of this slide, or if you can just remember the importance of G protein coupled receptor, and you can sort of pick that option as the answer, that's all you really need to tackle that question. But, you know, another important consideration here is the conversion of clopidogrel to an active metabolite, and that's also true for prasugrel. And as I'm going to discuss, data from the Plato trial is not true for ticagrelor. So, but I'm going to go over those mechanisms. But I think the take home for this slide is the importance of G protein. I'm just repeating that again, G protein coupled receptors for the mechanism of action for the ADP receptors. I think that's one important question. So that should be a gimme now for those of you who play golf. Should be a gimme on the test. And then let's also talk about the three ADP receptor antagonists which are commonly prescribed in our practice. You know, one is clopidogrel, the other one is prasugrel, and then the third one is ticagrelor. Of the two, clopidogrel and prasugrel are irreversible. I repeat that, clopidogrel and prasugrel are irreversible ADP receptor antagonists. Ticagrelor happens to be a reversible one. The reason I stress upon it, you're going to get tested on it. So the only reversible ADP receptor antagonist is actually ticagrelor. Okay, next slide. So this is an old study. You know, I'm now into practice as an attending physician for 3 years, and before that I was you know, a structural heart fellow, an interventional fellow, a general cardiovascular disease fellow. Even during residency, I never prescribed ticlopidine. But it is still a prevalent question on the boards, and the question is, you know, which of these ADP receptor antagonists would lead to profound thrombocytopenia or neutropenia? So it's the neutropenic response following ticlopidine administration is profound. And then one of the most common side effects actually from the drug, which is a testable question, is severe nausea and vomiting on the Cath table. So, you know, I think the reason for me to put this slide was to go over some of the important testing questions for ticlopidine. You know, neutropenia is one, and then the other one is severe nausea and vomiting on the cardiac catheterization laboratory table. So keep those in mind. But this is an important study which looked at safety profile of clopidogrel before clopidogrel became the cornerstone of therapy in patients receiving PCI. At 28 days, as you can see, the primary endpoint for patients with events was significantly lower for clopidogrel compared with ticagrelor. Your event rate is 9.12% for ticlopidine versus 4.56% for clopidogrel, a very significant p-value at 0.005. All right, next slide. So this is a meta-analysis, again, you know, which was published in JACC, led by Dr. Bhatt, you know, comparing all the data for clopidogrel versus ticlopidine, again showing at the very bottom row of the slide, as you can see, that clopidogrel, you know, all comers fared a lot better than ticlopidine did. Okay, next slide. So now this is important, and I'm going to share a few board questions here, which I think are going to be, I think, you know, very questionable items for the boards. So you have to know PCI cure. You know, there will be a question stem which will specifically say the PCI cure study, and it'll specifically ask you about these endpoints. It'll ask you about cardiovascular death or MI, you know, from randomization, and that's the reason why I put this slide up here. So what PCI cured, this was a sub-study. This was a PCI sub-study of the CURE trial, which, you know, was the clopidogrel trial. And the PCI cure study, what it demonstrated was there was a 31% relative risk reduction if clopidogrel was added to aspirin. So I repeat that, a 31% relative risk reduction, I think over about 3% absolute risk reduction when clopidogrel was added to aspirin. Now, the reason why cure is important is they're going to ask you about pre-treating a patient with NSTEMI who is being parked in the cardiovascular ICU or on a telemetry bed, and it's a weekend. And that data comes from the CURE study. So it showed that there was a benefit to patients who were pre-treated. I know this may be just routine information, or not even some of the information we think about now in the way we contemporarily practice interventional cardiology. I mean, everybody is sort of preloaded, or at least has dual antiplatelet therapy on board before they come to the cath lab, if they're hospitalized inpatients. But that, did not used to be the case. And you can sort of see that because the median time to PCI was 10 days. So again, historical data of historical relevance, but, again, important to know that pre-treatment as shown by CURE is what led to, some of the earlier studies in approval of clopidogrel. So just keep that in mind for the boards. All right, next slide. And this again is just a CREDO trial. So this is just long-term benefits of clopidogrel in patients with PCI. This is what sort of made dual antiplatelet therapy as mainstream, for us. And again, it showed that there was a 27% relative risk reduction, from 11.5% in the placebo arm to about 8.5% in the clopidogrel arm. So nothing more to share, other than the significance for, long-term, so 1 year benefits of clopidogrel in PCI patients, or 1 year benefits of dual antiplatelet therapy in PCI patients. So I think for studying the boards, if you have to review some of the trials in pharmacology for antiplatelets, I think for clopidogrel, the important ones to review are CURE, PCI cure, and CREDO. Again, I repeat, you are going to get tested on these trials. You will find question stems directly from these trials. So, just for the board prep, keep these trials in mind. And that's the reason why I included, or retain these slides from Dr. Bhatt's talk, which is a great talk, by the way. All right, great. Next slide, please. Okay, so prasugrel, so again, a testable board question. So the conversion of clopidogrel to its active metabolite is a two-step pathway. The conversion of prasugrel to its active metabolite is a one-step pathway. So keep that in mind. So ticagrelor, no conversion is required. Prasugrel is a one-step conversion process. Clopidogrel is a two-step conversion process. So it goes hydrolysis by esterases in the intestine. There's obviously rapid absorption after oral ingestion. And I'm gonna touch upon absorption in the intestines is an important topic, particularly with regard to its interaction with some of the administration of opioids, so particularly fentanyl or morphine in the cath lab. So just to share some of the pearls from my own practice, which is fairly young, but I typically usually do not administer fentanyl at all in the cath lab. I know it's sort of a sine qua non for any intervention or even a diagnostic procedure. Like, as soon as the patient's on the table, physicians would usually start administering by starting at least 1 milligram of midazolam and 25 micrograms of fentanyl. That does not happen to be my practice. And one of the reasons for that is, impaired absorption of P2 white 12 receptor antagonists, particularly with the administration of fentanyl, is Bill McEvoy's work, which was presented at ESC in 2017 and was also published in a leading journal. I forget which one, but I'm happy to share that paper with the audience if there's interest to review that literature. And then there's oxidation by cytochrome P450 in the liver, conversion to its active metabolite, which then acts on the ADP P2 white 12 receptor and sort of works in activating platelets in that fashion, decreasing their activity. Okay, next slide. So this slide is 3 board questions, okay? And I want you to specifically focus on that, and actually maybe 4 board questions. So We're going to go over the design of Triton TIMI 38 because this is a heavily tested trial for the boards. The first important fact about Triton TIMI 38 is that prasugrel was administered after coronary anatomy was defined. So if there is a question asking for loading someone with prasugrel before anatomy was defined, so in the emergency department or in the ambulance, never answer prasugrel because that's not how the trial was done. Prasugrel was only administered after coronary anatomy was defined. So that is an important board question. Just keep that in mind. Now, 3 more board questions. So we know there's an FDA black box warning when it comes to prasugrel administration in patients with prior stroke or TIA. So important to ask these questions when you're trying to administer prasugrel. I think particularly in light with ISAR React 5, which was, I believe, presented at I forget which meeting was it. I think it was probably TCT last year is when ISAR React 5 was presented and published simultaneously in the New England Journal. So important to have stroke or TIA history in mind. Then age, it didn't really show much of a benefit when someone was over 75. It did not show a greater signal for harm. You can see the p-value is 0.18. So for example, compared with stroke, it was very significant, or TIA, and then low body weight. So you are going to, so remember 3 things with prasugrel, or 4 things. You have to define the anatomy, that's 1. You have to ask about history of stroke or TIA, that's 2. Age is important, so less than 75 or greater than equal to 75, so that's 3. And then weight, less than 60 or greater than equal to 60, so that's 4. So again, very important slide, heavily tested topic. Please keep this in mind for the boards. All right, next slide, please. And then this is again a really interesting sort of an editorial which was written by Dr. Butt, intensifying platelet inhibition, navigating between Scylla and Charybdis. So what he was really trying to get at was that we are really between a rock and a hard place when it comes to balancing ischemic events and bleeding events. And our goal is to minimize bleeding events, and our goal is to maximize ischemic potency of our drugs. My next sort of slides are going to impress upon what we've done and where we've come in terms of minimizing bleeding and maximizing, ischemic or anti-ischemic potency, if you will. All right, next slide. So I've sort of gone over this. So, ticagrelor actually has a very rapid intestinal absorption because there is no in vivo biotransformation that is required, as I've mentioned previously. So the active compound does not. It's essentially after the intestinal absorption is available for the active compound is available for binding to the ADP-P2Y12 receptor on the platelets. And then again, G protein, the G protein you can see in the schematic here plays an important role because it's a G protein mediated receptor that results in inhibition of platelet activation. Next slide. So the Plato trial, right? Again, you're going to get tested on this trial, a very important trial, which led to the approval of ticagrelor. It was compared head-to-head with clopidogrel, which was, by then sort of standard of care. On the x-axis is days after randomization, and your cumulative incidence of clinical events is on the y-axis. As you can see, your hazard ratio is 0.84, so in favor of ticagrelor, with a highly significant p-value of 0.0003, extremely tight confidence interval, so 0.77 to 0.92 is your confidence interval. And the cumulative incidence was 9.8% in favor of ticagrelor versus clopidogrel, which was 11.7%. All right, next slide. And then these are some of the secondary endpoints. So myocardial infarction and cardiovascular death. So these are the important secondary endpoints. Remember, the first slide was the cumulative incidence of all, a composite endpoint, and these are sort of the secondary endpoints looking individually at MI and death. And again, you see that there was a significant reduction in both of these secondary endpoints in favor of ticagrelor. So I would say about a percent difference with the hazard ratio of 0.84 for myocardial infarction and 0.79 for cardiovascular death. So again, in favor of ticagrelor. All right, next slide. And this is, so each time you'll introduce a potent P2Y12 receptor antagonist, you're going to offset the ischemic benefit with some of the bleeding risks. And this is what this slide shows. So there was more bleeding with ticagrelor than there was with clopidogrel, at least the non-cabbage bleeding, which means, the bleeding interventionalists would most commonly see. And the bleeding was significant. I mean, it was significantly higher in the ticagrelor arm compared with the clopidogrel arm. So 4.5% versus 3.8% for non-cabbage major bleeding, and 2.8% versus 2.2% for TIMI major bleeding. And those are just some of the different definitions that were used for the endpoint adjudication for the trial. Okay, next slide. So that's the take-home message from that slide is that you are offsetting the ischemic benefit which are deriving from ticagrelor administration with some of the bleeding events. So again, could be a testable question. They could ask you that in the Plato trial, what were the bleeding, what were sort of the bleeding endpoints? Were they in favor of clopidogrel or were they in favor of ticagrelor? Again, very, very testable question. So keep the bleeding data in mind as you're preparing for the boards, at least from a pharmacology perspective. All right, next slide. So this is a neat paper. It came out last year. I think this is the first time we actually have a monoclonal antibody which is specifically directed against reversing a P2Y12 receptor antagonist, in this case ticagrelor. I think it still does not have a name. It has this sort of compound name, which is PB2452, but it was published in the New England Journal. And what it shows you that after a prolonged infusion of 18 grams, there was actually sustained reversal. 5 minutes after the initiation of infusion, sustained reversal of the effects of ticagrelor, and they lasted for about 20 to 24 hours. With a 16-hour infusion. So I'm not sure that the boards are going to test yet because I think it's fairly recent. But again, something to keep in mind. This was put on the expedited FDA approval list of drugs that the FDA would approve. So again, I think it's an important advance. It's a major advance. I think we're preparing for the boards, but these pearls and this information is extremely relevant and important for our daily practice also in the Cath lab. So just stay tuned for this compound to be expedited through the FDA process. And again, fortunately, we don't see a lot of intracranial bleeds with ticagrelor, but when we do, we should keep this agent in mind. So that was the reason for this slide. All right, next slide, please. Okay, so this is, I'm not sure it's showing correctly because I think maybe there was a formatting issue, but GI risk with antiplatelet therapy is again a heavily tested topic. You're going to be tested on the Cogent trial. You're going to be tested on the contraindication or the indication for omeprazole or pantoprazole, or PPI administration with dual antiplatelet therapy. So again, a very important topic because the boards would test you on topics which are fact-based, and pharmacology happens to be one of those topics which they can heavily rely on trial data and generate good questions. So I think in general, also for practice, if you've ascertained that there is a continued need for antiplatelet therapy in patients in whom you've just performed PCI, I think it's important to assess for gastrointestinal risk. So, the two questions I ask is, any history of, peptic ulcer disease or any history of upper gastrointestinal bleeding. And if the answer to that question is yes, I want to make sure that they've been tested for Helicobacter pylori infection. The reason for testing that, the reason for testing patients for that particular infection is because it's very treatable. It's a 14-day course. And, I think, so one more thing I want to stress upon here is that as interventionalists, our job is just not putting a stent in, or our job is just not to do a procedure. It's extremely important. And you'll see this, in independent practice, your colleagues who are, so both cardiologists and also, non-cardiologists, so people from other broad specialties in medicine, are going to look up to you for making these decisions, whether it comes to, other medications which interact with dual antiplatelet therapy or other comorbidities that require treatment. They're going to look up to you. So you'll have these multidisciplinary discussions and conversations about oncology patients, about patients who've bled and who are now seeing a gastroenterologist, about some of the lipid lowering therapies with endocrinologists. So that's why I think just to keep up on pharmacologies is crucial for us as interventionalists, because it translates into better patient care, more involved patient care, and then your colleagues rely on you for being dependable and always being approachable. And I think those are very important assets as we are exiting the controlled and the safe environment of fellowship and venturing out and taking care of patients. So sorry for that tangential thought, but I thought it was important to mention that as I was discussing this slide. Just ask as you're about to, I typically ask these questions when I'm consenting a patient and I'm anticipating there's going to be PCI. I always ask about bleeding history. I ask about history of peptic ulcer disease. And then, if the answer, or you could also chart check, it's the decade, or the days of electronic health record, you can chart check and see if there is any past medical history of peptic ulcer disease. Sort of important to keep that nugget in mind as you're consenting the patient. And if there's any one of the following risk factors, again, a testable question. So steroid use, symptoms of gastroesophageal reflux, or age more than 60, it's not a bad idea to institute therapy with proton pump inhibitors. And then my next slide is going to talk about the safety of proton pump inhibitors with clopidogrel, because that was when this question was brought up for a possible interaction between the two agents, and that's when this trial was done. So next slide, please. So the COGENT trial essentially looked at omeprazole versus placebo and the effect of proton pump inhibitors on GI events. And what it shows here is that the probability of freedom on your y-axis, so probability of freedom from primary gastrointestinal endpoint, was better with omeprazole compared with placebo. As you can see, a hazard ratio of 0.34 and a p-value of less than 0.001. So settling any issue with possible interactions. And if you have to use a PPI, I think omeprazole is a good one, is a good PPI, even although I think it's a class effect, so I would even use pantoprazole. All right, next slide. So again, this is to hone in on what I was saying a couple of slides ago, and that was it's important for us to be on top of pharmacotherapy for our patients, because once these patients have a procedure, and hopefully if it's an outpatient admission, then it's a same-day discharge PCI. Most of our cases are radial, or if it's in the setting of an acute coronary syndrome, then most patients go home within 24 to 48 hours, and then they're going to follow up with their other doctors. So I think bleeding reduction strategies become extremely important and very relevant for interventionalists, right? So is a big bucket, and you have to think about many things, right? Radial access, lowest effective dose of aspirin, minimizing duration of dual antiplatelet therapy. These are all important considerations in patients who are treated with warfarin, targeting INR to a lower therapeutic range, routine addition of a PPI, which we discussed in our last slide, avoiding concomitant use of non-steroidals. It's extremely important, and this is something which I think you'll appreciate once you're in practice, and that is, doing your own medrec after you've put a stent in is very important. You'll see how much changes you make to the therapeutic regimen, and I think I think we should take that upon us, because really the amount of nuanced knowledge and information that interventionalists are exposed to when it comes to antiplatelet therapies or anticoagulant therapies, is a lot more compared with some of our colleagues in general cardiology. With all due respect to them, but even some of our colleagues in general cardiology wouldn't have as much nuanced information, as we do. Again, just keep bringing these questions in the chat. I do see a couple questions. I'm going to get to them at the end of the talk. And then also in patients treated with novel oral anticoagulant, use the lowest effective dose for stroke prevention. And then, preferential use of clopidogrel over prasugrel or ticagrelor for inhibition of P2Y12 receptor antagonists. Again, something which commonly comes up, and I'm sure there will be questions around this. Okay, next slide. So important to sort of, I haven't really, this is a separate topic in and of itself, and I'm sure the organizers have put that as a topic for discussion, but use of stent technology and what stent to use. This is just a slide to impress upon the audience that, through the decades of PCI, over 40 years, we've come a long way. And to safely say actually that, second generation of everolimus-eluting stents have become the gold standard of PCI in 2020, or I should say remain the gold standard of PCI in 2020. So second generation drug-eluting stents remain the gold standard. Actually, I'm not even sure when was the last time I used a bare metal stent. I actually haven't really. And what the slide shows is, even as early as 30 days, you see a clear difference in stent thrombosis rates. Look at the cumulative incidence of events. The blue line is bare metal stents. The red line is everolimus-eluting stents. The hazard ratio against the use of bare metal stents is 2.75. That's not a trivial hazard ratio. Okay, so the point I'm trying to make is, you could argue decreasing the duration of dual antiplatelet therapy in patients you think are high-risk bleeders. And I'm going to go over some of the DAP strategies with you in subsequent slides. But I don't think, I think putting a bare metal stent in someone is clearly an inferior strategy, in my opinion. Even in high risk bleeders, you could argue decreasing the duration of dual antiplatelet therapy, as short as 1 month or even 3 months, even 1 month. And now we have new data which is looking at monotherapy, so single antiplatelet therapy with a single P2Y12 receptor antagonist like clopidogrel or ticagrelor, and dropping aspirin, which is something I've incorporated in my practice, in lieu of the recent circulation paper that we published, with Dr. Stone and Dr. Bhatt and Dr. Kapadia. I don't have that slide with me, but I'm happy to share that paper on DAP strategies with the organizers and with Poonam. All right, next slide. So, this is a really nice editorial that Dr. Bhatt had written, which was published in Lancet. And what he was trying to argue here was, is there enough in terms of data that we could say that second generation drug-eluting stents actually have been shown to have a reduction in death in myocardial infarction? Hard to make that statement, quite frankly, but is good food for thought. And I think is a very well-written editorial if any one of us is interested in reading it. Would be, I'm sorry, I'm getting a little distracted because I have questions popping on my screen, but again, I'm going to get to the questions. But what I was saying was, it's an important editorial to read because it really goes over the evolution of stent technology and sort of where we are now, and how we got here, and what have been some of the improvements and iterations in stent technology that have made stents actually very safe, particularly when it comes to bleeding risk. All right, next slide. So again, I've sort of said this, and this is an analysis by Dr. Bangalore and NYU, and what he showed here was that everolimus-eluting stents have clearly become sort of the community standard, if you will, for PCI in our contemporary practices. Okay, next slide. So, coming over to DAP, right, and coming over to basically asking yourself, what is the best duration of dual antiplatelet therapy in patients in whom you've just put a stent in? These data continue to evolve, actually. As I was alluding to a couple slides ago, We did a network meta-analysis, which was recently published in Circulation. It's actually one of the most comprehensive works done to specifically address the question and this topic, and that is, what is the optimal duration of dual antiplatelet therapy? And what we've shown was that you could say that these findings are intuitive, but a lot of work went into network meta-analysis because we included data from 24 trials. So what we showed was that you will significantly reduce risk of MI and other major adverse cardiovascular events with prolonged duration of DAPT, but that'll be at the expense of bleeding. And if you prolong DAPT, then your net adverse clinical events will go up, not in favor of ischemic events, but you'll have more bleeding. And that's why the net adverse clinical events will go up, because your bleeding has gone up. So how do you sort of individualize that decision for every patient? So it's not a straightforward decision. I mean, I think every patient is different, as all of us appreciate that every person is different. This is one of the scores which was published, I believe, in Lancet. Dr. Butt was involved, Dr. Greg Stone was involved, and this is looking at precise DAPT. So they looked at variables which are very commonly available just using electronic medical records. So a lot of us use Epic. I know there are other vendors out there, but something electronic medical records can easily populate automatically in patients who have PCI, and that is a precise DAPT score. So hemoglobin, prior bleed. So as you can see, prior bleed has a lot of weightage points on this algorithm. So 26 points. And so it's the most heavily weighted variable, if you will, in calculating the precise DAPT score. White blood cell count, which is just a global ubiquitous marker of severity of illness. Could be any kind of illness because it's an acute phase reactant. Then age and creatinine clearance. So it's a mathematical algorithm, and it'll spit out a score. And our cutoff is 25. So if you go to the next slide. So your number to remember for the precise, with precise DAPT, the number that you have to remember is 25. So anyone that scores more than 25 is at a higher risk for bleeding and will benefit from shorter duration of dual antiplatelet therapy. Now, this also includes patients in the acute coronary syndrome subgroup. I know our guidelines, so both the American and the European guidelines actually say that in patients with ACS in whom you've put a stent in, the optimal duration remains 12 months. And then in someone with stable ischemic heart disease, you could argue that it's 6 months. There are data evolving. And, a lot of the contemporary trials have actually looked into this. And that was one of the reasons why we did that network meta-analysis, which was out in Circulation. A lot of the newer data have actually looked at ACS patients as well. They've specifically looked at the ACS subgroup as well. And they've clearly shown that in patients who are at high risk of bleeding, so have bleeders, it is safe, even after an ACS, to discontinue DAPT. For example, after 3 to 6 months, a shorter duration of DAPT in high-risk bleeders will give you net adverse clinical benefit in favor of equivocal ischemic events and less bleeding events if you can cut down your DAPT earlier. So that's the take home. And in patients who are at low risk, so if your precise DAPT is less than 25, sure, I'd keep them on dual antiplatelet therapy, for 12 months, or as the DAPT trial showed, even 18 months. And this may be a namesake, but may not be a namesake. So this is the score that I'm just talking about right now is precise DAPT. There's another score out there, which is the DAPT score, which was the Laura Mori Bobby A paper, which has been incorporated into the American College of Cardiology guidelines. And there is a risk calculator, which is online, which is available, which you can use. So the DAPT score takes into account many procedural variables, which the precise DAPT does not take into account. So the precise DAPT is only taking into account, variables which are very commonly available, from electronic health record or electronic medical record of patients. The DAPT score, looks into lesion complexity, the number of stents that were put in, the complexity of the procedure, obviously some of the patient variables. So you could use either or, but precise DAB just happens to be, with the global variables that have been used to come up with the score is just a lot easier, I think, to use. That's all. All right, next slide. So yeah, we've talked about this, right? So non-high precise DAPT, there was an ischemic benefit with longer term administration, so 12 months to 24 months without an increase in bleeding. In high precise DAPT score patients, there was no ischemic benefit with longer duration, but there was an increase in bleeding. So in patients with a high precise DAPT, which is more than 25, so greater than or equal to 25, you're better off in using 3 to 6 months of dual antiplatelet therapy compared with, for example, 12 to 24 months. Okay, next slide. Okay, now, so going over some of the data on anticoagulants. So bivalirudin, I know I haven't used it in contemporary practice ever since the HEAT PPCI was published by the group in London, Rod Stables and Adil Shahzad. Those are the two authors, and I believe was presented at ACC the 2013 or 2014 seminal paper published in Lancet. I think all of you should read it. I haven't included that in the slide sets because again, I was trying to prepare for this talk last minute, and I, thanks to Dr. Bhatt, he just lent me his slide sets. I couldn't insert some of the slides, but I'm happy to, the papers that I'm bringing up in the discussion, I'm happy to provide them, for the listeners. So bivalirudin is a direct thrombin inhibitor. Next slide. It basically binds directly to thrombin, and that's how it's reversible binding. So again, important board question, reversible binding. Bival binds reversibly to thrombin. That's a board question. Okay, so that's why I'm including these or sort of retaining these slides so that you sort of have image memory as you're answering your questions. Next slide. So the one of the first trials for bivalirudin was the REPLACE-2 trial, and what it did was it compared bivalirudin alone with the combination of heparin and a 2B3 antagonist, which at the time was standard of care. Okay, and the bolus dose was 0.75 milligrams per kilograms, and then the infusion was 1.75 milligrams per kilograms per hour. So it was a 1-to-1 randomization. And your endpoints were death, MI, revascularization, and hemorrhage at 30 days. And then they also looked at cost effectiveness. Okay, next slide. So at 30 days, you clearly had, this is bival. So if you look at the composite endpoint, this is the percentage of patients. So bleeding was in favor of bival, even though it was at the expense of some thrombotic events. You can see there's more MI in the bival, but this was not statistically significant. It was 0.4, so but numerically higher, but not statistically significant. But if you look at major bleeding on the right, it was significantly lower with bival compared with heparin and 2B3A, with a p-value of 0.001. So that was one of the first trials. It was published in JAMA. All right, next slide. And this is mortality. So a 1-year mortality overall result, death rate was lower with use of bivalirudin at 12 months. So 1.9 versus 2.5. P-value not significant, but again, just a signal for benefit when it came to bival at 12 months. And I'm gonna show you Horizon's AMI data, which is what really led to the approval of the drug. So next slide. Now this is IZAR React. So this is this looked into patients who were at low. So these are low risk patients. These are if you were to do a GRACE risk score or a TIMI risk score. So again, important from a board perspective to know what GRACE risk score is and what TIMI risk score is. You're going to get asked questions on how to score patients based on GRACE and risk. GRACE, you need a computer. You can't just do it on your own. TIMI, you can actually just do at the bedside. But important to keep these risk scores in mind for non-ST elevation MI patients. So this is low risk GRACE, low risk TIMI. You've decided that you want to take these patients to the cath lab. And this is loading clopidogrel upfront, and then randomizing patients to receiving either apixaban or heparin or placebo. And what this trial was really trying to address was, is there any benefit in upfront administration of clopidogrel along with aspirin? Now we know it's second nature. We a lot of us just upfront treat these patients with dual antiplatelet therapy, or at least load them with clopidogrel even before they're coming to the lab. So this is of historical importance, but one of the trials which you may actually get tested on. All right, next slide. So what this showed was that this was in favor for loading with clopidogrel, and this is ISAR React. So this is days after randomization, and this is the incidence of primary endpoint. So this is the results of the efficacy analysis. Your relative risk is 1.05, but it's straddling 1. So, numerically different, not entirely different. You've got overlapping Kaplan-Meier curves. All right, next slide. So the safety analysis, again, you'll see apixaban. I bring this up because apixaban and thrombocytopenia is going to be a board question. You see that there's more bleeding with apixaban. So, the trial basically showed that in an era where you have contemporary use of P2 white 12 receptor antagonists, whether it's ticagrelor or clopidogrel or prasugrel, I think 2B3A, the role of 2B3A is sort of dwindling. I mean, I personally have not used 2B3A in the lab. I don't use it in, I think, upwards of 99% of patients. There may be one patient with a significantly heavy thrombotic burden, and I'm sure this is going to come up in the discussion, or we can discuss it in the Q&A session. But otherwise, fairly is just heparin, ADP antagonist, radial access, and that's how we do most of our PCIs. All right, next slide, please. So this is an important study. So next slide. So we've talked about this, right? I mean, major bleeding is an important endpoint, is a very important endpoint for interventionalists, as is ischemia and stent thrombosis. And I think our challenge is to maintain that balance. Okay, next slide. So there's a paper by Dr. Stone. I think it's going to come up in a couple of slides, but this is, again, one of the other trials which looked at bivalirudin with heparin and 2B3A. In the interest of time, I'm gonna skip the details, but what it basically showed was, go to the next slide. So next slide, please. I just want to get to the next. Yeah. So what it showed was, you can go back one slide, please. Sorry about that. Yeah, so I just want to spend 2 minutes on this. So, what it really showed was that, the hazard ratios were in favor for, bivalirudin when it came to bleeding, overall bleeding risk. And, when there was, I think, an overall mortality benefit. So in terms of ischemic endpoints, bivalirudin was similar compared with the combination of heparin and 2B3A. In terms of mortality, it was similar. Actually, one of the slides that there was a mortality benefit. And then in terms of your bleeding, it was significantly better. So, bival alone, based on the combination of 2B3A and heparin versus bival was clearly a winner. But as we know, it has changed now, because if, again, HEAT PPCI is a trial that you all should read. It compared bivalirudin alone with heparin alone, and actually showed a benefit for heparin. And there was more stent thrombosis with bivalirudin, which we know, happens, has been shown even with the Horizons AMI data, that there's more stent thrombosis with bivalirudin. So this is going to be a board question. So there's going to be a board question on bivalirudin and stent thrombosis. All right, next slide.
Dr. Kalra, I think we may have lost your audio.
Yeah, no, I thought I was kicked out of the meeting. Can you hear me?
Yeah, we can hear you.
Okay, great, thanks. This is an important paper. So what this paper actually shows is that major bleeding actually leads to the importance of major bleeding in the overall outcome of the patient is profound. Look at the hazard ratio of major bleeding and compare it with the hazard ratio of MI, and look at those p-values. So what you'll see is that major bleeding is not a casual endpoint, and that's why the field has sort of moved to looking at net adverse clinical event rate as a hard endpoint, countering in major bleeding. So that was the message from this paper, and that was the reason for including this paper. Okay, next slide. So this is Horizons AMI, and this is similar to Acuity and similar to even the first BIVAL trial. But for the interest of time, I'm going to skip this because the message is the same. But for the boards, it's important for the audience to just go back and read, just briefly read the endpoints for Horizons AMI. Go to the next slide, please. Yeah, so keep this slide for the boards. What it showed was 24% reduction in net adverse clinical event rate with BIVAL, and reduction, 41% risk reduction. This is all relative, again in favor of bivalirudin alone. And you're comparing it with heparin and 2B3A, and your major adverse cardiovascular events were actually very similar. So, if you factor in major bleeding, that's what's driving your net adverse clinical event rate at 30 days. Okay, next slide. And this is mortality data. So this is looking at, mortality at 30 days. The curves start to separate as early as 1 month. And then there's clear diversion, but this is, again, using heparin with a combination of 2B3A, which I don't believe is contemporary practice anymore. But BIVAL here showed a mortality benefit at 1 year. It was published in The Lancet by Dr. Mehran, and was a very popular drug until HEAT PPCI got published. All right, next slide, please. Yeah, so we've gone over this. Next slide, and I think, for the interest of time, I'm probably going to stop here and, take a few questions, if that's fine with the audience. Hello, can you?
So Dr. Roy, do you want to go ahead and moderate the questions? Not sure if he's...
Yeah, yes, I'm just gonna read some of the questions I have. So the first question, there was a question about omeprazole and Plavix concomitant use.
Yeah.
Is it okay, or is there
okay.
an interaction?
It's okay. The drug interaction was based, was a question which was raised based on data from observational literature. And then we had a randomized trial, the Cogent trial, which was a New England paper. Dr. Butt was the first author, and it showed, there was no signal for harm. There's actually signal for benefit.
The second question I have is about the safety of use of ticagrelor with NOACs.
So, again, there are trials now. I mean, the Redual PCI is the most recent one. So the answer is yes, it is safe. I actually use it routinely in my clinical practice, and I've had no issues with either tolerance or increase in bleeding. I can remember one patient in which there was a bleeding, but that was in a patient with a history of bladder cancer, and he needed to get that tumor removed. But short of that, very safe and very effective. So no issues with ischemia.
And what are the situations where you would preferentially use clopidogrel over ticagrelor?
Yeah, so you'll have patients who are not able to tolerate the drug because of dyspnea. That happens, and that's because of the metabolite causing ciliary dysfunction. In those patients, you would have to switch to clopidogrel. Then some patients will actually also have a bradycardic response. to ticagrelor. And those patients, I probably switch to prasugrel or switch to clopidogrel, either or.
The next comment and question I have is both DAPT and PRECISE-DAPT studies, they basically largely included patients who tolerate DAPT without bleeding, at least for some duration before being included in these studies.
Good
Any
comment.
thoughts for using these data for initiating drugs and de novo patients, post-PCI patients?
So I know this question is from Saurav, and Saurav, I'm happy to answer this for you. We can talk in person, but if I understand correctly, are you asking whether it is safe to use? I'm not sure I understood the second part of the question. I agree with Saurav that these data are, primarily on patients who actually demonstrated tolerability of dual antiplatelet therapy. But if the question is that should we extrapolate these data to patients who are bleeders, I think that remains a data-free zone. If I'm not mistaken, Saurav, you can correct me if I'm wrong. But it's an important question. Yeah. So it's a question of extrapolation. I'm not sure. I don't know is the right answer, Saurav. Maybe you and I should do a study on it. But I agree.
The next one I have is a question on triple regimen post PCI. Any comment on that?
Yeah. So I think upfront, if your patients can, I think there are data which are now commenting on upfront use of dual antithrombotic therapy, as it is called. So a single antiplatelet agent and a single antithrombotic agent. So dual antithrombotic therapy. That's the new term in the literature. Upfront, you can use it. I actually have used it in my patients. So if someone has underlying AFib, has been on a NOAC or a DOAC, like apixaban, rivaroxaban, dabigatran, comes in, has a PCI, I put a stent in. I administer the loading dose of the P2Y12 receptor antagonist, and then I usually discharge those patients on that P2Y12 receptor antagonist and the DOAC. I don't discharge them on aspirin. There is a really nice paper by Davide Capodanno and Dr. Butt and Dr. Stone, I believe, are co-authors, published in JACC not too long ago, I think within the year. They have a really good central illustration specifically answering this question. So I highly recommend the audience to read that paper. What they recommend is, at least for a month, keep patients on triple therapy if they can tolerate it, and then move to dual antithrombotic therapy. I tend not to follow that. I've had no clinical events to report so far. But again, I'm 3 years into my practice, and I'm sure there are more experienced operators than myself. But the data are there for its both its safety and its efficacy.
I think in the interest of time, we'll just stop here, and we can answer the rest of the questions. We'll upload them on the website. I will. Thank you so much, Dr. Kalra. Yes, I will email you. Yep. Yeah, I will email you, and then we'll upload it on the website.
Yeah. Okay. Sounds good. Thank you very much.
Thank you very much, Ankur. That was an excellent talk. Thank you for doing this. We will be uploading the whole slide set, and we will be sending the questions over, or we can even put him out to the panel today. I would like to invite the rest of the panel to join us. Manos and Samir, I think you're on the call as we speak. We are going to have a case presentation by Dr. Sanjog Kalra, who was born and raised in Edmonton but moved to Toronto in 2000, and he has done his training at University of Calgary and then at Dalhousie University. He did his advanced cardiac Cath fellowship at Toronto and interventional fellowship at St. Michael's. He also he was selected as the first complex high-risk and indicated patient fellow at Columbia University Medical Center, and he gained his expertise in complex and high-risk interventions and CTOs and PCIs at that point. He is nationally and internationally recognized as an expert in advanced coronary vascular techniques, And he recently concluded his role as the Director of Complex Coronary Therapeutics and Associate Director of the Interventional Cardiology Fellowship Program at Einstein Medical Center in Philadelphia, Pennsylvania. And he is going back to Toronto to join the Peter Monk Cardiac Center as the Interventional Cardiologist and Cardiac Critical Care Physician at the University of Toronto. Dr. Kalra, if you want to share your slides and proceed with your case presentation at this time. And
thank you very much for the generous introduction. It's always hard to follow Ankur because he's so knowledgeable, so I'm going to do my best. It's a real privilege to have such a distinguished panel to be able to pick on as we go through this case presentation. And most importantly, I'm really thankful to be able to contribute to some of the fellows' education. I, like Ankur, am not that far away from my fellowship, and so it's been a real pleasure being an early adopter in this sort of CHIP, so-called complex PCI space, where I've had the opportunity to interact with people. So I look forward to lots of discussion. I'll try to stop intermittently as we go. I was asked to do something to organize wires. I realized that this is not a specific board topic per se. I wrote the Cath chapter in Cath 5 on CTO PCI a few years ago, and I remember that we put some information in about tool selection and wire selection based on how wires are designed, but that was a pretty brief table, and so my hope is that we can go through some of that today. These are my disclosures. So wire selection in CTO PCI is a challenging enterprise. It's all about trying to get the nail to get hammered into the wood just right. The problem is sometimes we pick wires that do this, right? Where one shot ends up being a very, very big mess. And other times we end up being incredibly frustrated and increasingly challenged because we can't seem to find the right tool for the job. The reality is, in the setting of wires, we're embarrassed by riches. This is an incomplete list of the very many wires that we have available for CTO PCI. And I would not challenge anybody to try to know everything about each of these wires, because I think it's going to clutter your brain and it's probably going to make it harder for you to do your job. So this is one way to try to organize these things, where you start organizing them based on specific characteristics, non-jacketed versus jacketed, soft versus hard, these kinds of things. But the reality is this might also drive you to drink because there's just too many choices here. So my hope is to give you a few basic tools that you can use to try to understand this segment of the toolbox that we have at our disposal. And when you do that, you're going to want to ask yourself a few key questions. What is the task that I'm trying to accomplish? What are the tools that I have at my disposal? What is my expected result, i.e., where do I want to be when I'm done this maneuver? And then what's my next plan? Plan A, B, C, D, E, F, G, etc., which is what we commonly have in CTO PCI, because that is a game of iterating your experience, iterating your knowledge, and trying to solve problems as they come up. So the most important design features that impact performance of a wire are the distal tip and the characteristics of that distal tip. The core wire, so that's the wire that you see sort of in the middle of this tip, that courses right through the length of the wire. And then the coating, so what the wire is covered in and how that coating interacts with the surrounding environment. The distal tip can be talked about in terms of tip load, spring coil, tapering, and coating. So tip load is how stiff the tip is at 1 centimeter from its tip. It's a measured quantity. And so each wire has its own sort of tip load, but tips can be grouped into those wires that are heavy tip load or high tip load versus those that are lower, versus those that are moderate. Spring coils, which are coils that come around the core wire out to the tip of the wire, help you transmit torque. They help you turn torque that's being put back here 190 centimeters away into movement here. The tapering of the spring coil provides more penetration power. So as you can imagine, force over area is your penetration power. And so if you apply a force over a tiny tapered tip, you're going to have more penetration power than if you have a large blunt tip. And then of course, coatings enhance or detract from the tactile feedback. So to increase penetration, you're going to want a wire with a higher tip load. Or you'll want to choose a wire with a tapered spring coil or a tapered tip to improve tracking. And this is an important term that you need to understand. Tracking means how well the wire moves through the vessel, not how well equipment will move on the wire. That's a separate issue. So to improve the wellness through which a wire will move through a tortuous vessel, you want something with a relatively low tip load, something that is lubricious, so hydrophilically coated, and then something with a smooth or even parabolic core taper. Okay, and we'll get into those details in just a moment. And then something that will improve your tactile feedback will have a less lubricious coating than something that will not give you tactile feedback, but that may move through the vessel slipperier and easier. So the fundamental trade-off there, the higher the tip load, the better the penetration. But the more that wire wants to go straight and will not track the vessel. The core wire can be thought of as thickness, material, so stainless steel or nitinol, and abrupt or smooth taper at the end. So we're talking about this segment here when we talk about taper, right? As you might imagine, rebar, sort of the large poles that we use to make metal fences, rebar is a thick metal. And if you turn rebar at one end, you'll see one-to-one turns at the other end. That's very different than something like a copper wire, where you might turn grossly at one end, but 190 centimeters away, the end is not going to turn as many times because it takes time for torque to transmit, and that torque transmission is a function of length. So a thicker core wire that is shorter is more supportive and transmits torque better. A thinner core wire, sort of spaghetti if you will track more easily, it'll bend along the vessel, but it's not going to transmit torque all that well. Nitinol is nice because as a core, it's very durable. You can bend it, you can beat it up, it'll snap back into its place. But because it doesn't like to hold the shape you put to it, it's not going to transmit torque nearly as well. Stainless steel, on the other hand, transmits torque better, but once you bend it and you create a deficiency within the core wire structure, you can't bend it back. And that wire is going to be with that shape. If you try to bend it back, you risk breaking it. And then a wire with a smoother taper, sort of the classical example might be the whisper wire, where there's a parabolic taper, i.e. the wire is very thin at the tip with respect to the core wire and then gets thicker and thicker as you go back. Those individuals will typically have, or those types of wires will typically have smoother tracking around tortuosity than those that have very abrupt tapers. So what you want when you want to improve guide wire tracking around a corner is take a wire with a thinner core or a parabolic core. To improve torque response, you want something with a thicker core, except when you have tortuosity. That's when you have to use the compound core wires that we'll talk about in a second. These are sort of good ways to cheat the physics around this thicker core wire, thinner core wire problem. And then to improve or support or to deliver devices, you're going to want a wire with a thicker core because they're more supportive. So the fundamental trade-off to understand about the core is the thicker the core, the better the torque response, right? The more it's like you're turning a big thick pole of rebar, but the more the wire is going to want to go straight. The thinner the core, the less efficient torque or turn response you have, but the more it's going to be willing to track the nature of the vessel. And then the last important piece is guide wire coatings. Just about all guide wires, I shouldn't say all of them because there are specialized guide wires that are not coated, but most guide wires have a coat, and the majority are hydrophilic coats, which allow wires to track and move through the tortuosity of the vasculature easily. There are some wires that are composite coated or hydrophobically coated, and really coating comes down to tactile feedback. So if you have hydrophilic coats, they are going to have slightly less tactile feedback than a hydrophobic coat, but more tactile feedback than a polymer jacket, which really is not going to have any tactile feedback. The classical polymer jacketed wires that we think of when we think of the older set of wires are things like Whispers or Pilot 50s or Pilot 200s. The classical hydrophobic tip wires might be the Miracle Brothers group of wires, or those that have exposed coils. So in general, the more you have lubricity, the more of a polymer jacket you have, the less you can feel it. The less polymer jacket, so the more spring coil hydrophobic covering you have, the more you can feel it. So when we try to choose a wire, what we want to do is choose the task that it's trying to perform, and then choose the wire that's going to match that task so that we can get success. And if you take nothing else away from this case that I'm about to go through, take these 2 slides away. This is adapted from Chris Buller, who is a senior colleague from whom I had the pleasure of learning and who is now a very senior member of the CTO community and of industry. He developed this task-based wire classification because really there are only 7 things that we ask these wires to do. We ask them to access things or function as workhorse wires. That's really what we do in typical PCI. There are those wires that are meant to subtotal occlusion track, so microchannel tracking, if you will, not necessarily through a microchannel, but those microchannels might mark areas of weakened tissue within a CTO body, so track through those weakened areas, or really track intraplaque. There's directed penetration, so wires that have high penetration power that poke through very tough tissue and allow us to advance our base of operations only to de-escalate to a different wire. Directed navigation, so those wires that are of moderate tip strength that have some penetration power, but that also have very careful torque control and can be moved gradually through the body of a CTO towards the distal cap. Those specialized wires that are used to cross collateral, sometimes vein grafts, sometimes septals, and more dangerously, if you will, or more carefully, epicardial collaterals for those who are very experienced. There are those that knuckle or basically blunt dissect. So find a subintimal wire position, push forward, and then dissect past the body of an occlusion. And then there are the externalization wires, the extra long wires. And these all have specific task-based wire classification properties. This is an awful lot to go through, and the engineering can get kind of difficult, but hopefully we can flush some of this out through the case. And I'm happy to make these slides available for you and for your review. Access wires in general, they have lower tip loads and they have moderate core thickness to allow tracking. Microchannel or intraplaque wires have tapered tips so they can engage the plaque. They're highly lubricious, often polymer jacketed, and they're a low tip load so that they can swim through or maneuver their way through the plaque. For those that intraplaque track, they're often moderate tip loads, typically pilot 200s, that can move through dense but not severely calcified or deeply packed down tissue. Directed penetration, very tapered tips, so you can apply more force per unit area with a high tip load, and something that you can feel, right? A hydrophobic tip. Versus directed navigation, where they need to be maximally torque responsive with a moderate tip stiffness and a flexible shaft so they can move through the body of tortuous occlusions. Collateral crossing are the ultra low tip wires, those very, very soft wires that we can take through the very fragile collaterals that we have to deal with. Knuckling wires are an important concept to understand. These are polymer jacketed wires, so things that'll slip into the subintima with a low to moderate tip load, but that can then create a knuckle based on the short core taper, so that the wire essentially tapers under a very short length and then has a little bit of tip out behind it, so that when you then push the wire, the tip prolapses into a knuckle, and then that core wire provides the push behind that knuckle to be able to bluntly dissect through the subintimal space. And then of course the externalization wires, they have extra length and they have flexibility around corners and through tortuosity. So we have a case of a 56-year-old guy who came from home, who's got the usual cardiac risk factors. He's got a recent discovery of an aortic aneurysm requiring surgery, and he's also got angina. He's on good medical therapy with 3 anti-anginals, Imdur, Ranexa, and Carvedilol. His treating cardiologist kept him on medical therapy for an extended period of time, despite his symptoms, because he was getting reasonable responsiveness, but the patient found that his activity was now being increasingly limited as a result of his symptoms. And that's why he presented to his physician for consideration. During that physical exam, an abdominal pulsation was noted, and that's what prompted an ultrasound and then eventually a CTA that revealed a AAA that required surgery. He underwent stress testing given his chest pain, and that revealed a fully reversible anterior septal and anterolateral perfusion defect. And so he was sent for diagnostic cath. So these are his cath films. So this is the right coronary artery. There's no important disease there, but you can already see that we're getting into trouble here, right? Where you have some collaterals coming up from the septum in a not particularly tortuous PDA, but with some fairly tortuous takeoff septal branches supplying the LAD. This is the LAO-caudal view. And I draw your attention to the fact, or excuse me, the AP-caudal view. I draw your attention to the fact that you can see a little bit of calcium moving out here in space, right? Because you have an occluded LAD. And that proximal cap is very ambiguous. It's very difficult to tell where this diagonal comes off and where the vessel actually occludes. This is the epicranial view. And what you see here is, again, you have a very, very difficult to determine proximal cap. And that's once again illustrated here in the LAO caudal view. So what you have here is a challenging CTO where you have some calcification, you have a very ambiguous proximal cap, but you also have a challenging scenario at the distal cap because there's a big diagonal branch that comes off right at the distal cap. Let's see if I can get this to play here. Right here at the distal cap. And that's probably largely the source of his anterolateral ischemia. The LAD is a tube that provides branches. And so if you just open that but chop off the big branches, you haven't necessarily done the patient much good. So I'm going to put this back to the panel and I'll ask any of them to chime in as they see fit. What's your take on the angiogram? Can you compute a JCTO score and or a progress CTO score? And then do you have an approach and any special technical considerations that you think you need to keep in mind? Manos, you wrote the progress CTO score. Are you there?
Yeah, thanks, Sanjog. That's actually a great case with a lot of complexities there as well. So I think you're right. This is a complex case because you do have an ambiguous proximal cap. You do have a bifurcation of the distal cap. The JCTO score, so if we look at the proximal cap is ambiguous, it gets 1 point. Then in terms of the lesion length, it looks more than 20 to me, so that's going to be another point. Then is there more than 45-degree bend inside the CTO? Hard to tell, probably not, so I wouldn't give him a point for that. There is some calcium, so I will give him a point for that. That's 3 points already. And then there's no previous attempt, so that wouldn't get a point for that. So that would be a JCTO of 3. So this is a complex CTO. This is not to attempt, for people who are beginning CTO, this is not a good one. And there are many risks, including, the ambiguity proximal cap can lead to perforation. The distal bifurcation can lead to losing the side branch. So many issues there as well. In terms of the progress CTO score, it would get a 1 point for the proximal cap ambiguity. Now, in terms of the collaterals, I didn't see very clearly if there's much retrograde septals over there, but
there are septals, but they're hard to tell. They're quite tortuous and they're very small.
Okay.
They're
So
sort
I
of
guess
blinking in and out.
we'll give it. So that would be, a 2 point for progress CTO, also in the complex territory.
And I'll prove tortuosity to you in a moment.
Okay, perfect. And then, so a CTA would be great for this to clarify things, but in terms of approach, given the bifurcation, distal cap, and the ambiguity, again, if there is any option for retrograde, that would be great. Now, we do say that you want to start with antegrade crossing first, if you can, and because of safety issues. So one option would be to use IVUS, see if we can determine the proximal cap. If we can puncture the grade, if not, then we'll have low threshold for switching to retrograde. Perfect.
So, I mean, this is the beauty of hearing a bunch of experts tell you how they would do these cases, because you hear all kinds of great plans. So just as Dr. Brilakis pointed out, there's ambiguity in the proximal cap. There are diagonals at both the proximal and distal caps. There's visible calcification and there's possible tortuosity. And this is now your dual injection film where you see in this areocranial view that you have some pretty tortuous septals, but they're pretty small. They blink in and out. And there is certainly calcification within the CTO segment. It's about 20 millimeters. So my plan when I did this was to get wire access into the first diagonal branch, that's that big guy up here, and use IVUS guided proximal cap puncture, and then try to navigate intraplaque. But understand that if I'm going past that distal diagonal in the subintimal space, I'm not going to want to do a reentry because I'm going to chop off that branch, and that would mean I'd have to do a bailout retrograde or a secondary attempt, which is retrograde. Okay. The other important piece is that you've got to recognize that if you're going to make reverse cart your strategy and make a connection here, you're going to want to make sure that you make the connection into maybe a guide extension catheter within the CTO segment. If you go beyond the CTO segment, you may dissect off that branch. If you go proximal to the CTO segment, you may dissect off the proximal branch. So that's one of the things that makes this case a little bit more challenging. So here's the IVUS catheter that I brought in, and here you can see the eagle eye IVUS, and here is where you can see your proximal cap. You can hopefully all appreciate that. As we pull back the IVUS and then go back forward again, you can see that the proximal cap is right here. Okay, and we angiographically co-register that proximal cap so that we know exactly where it is. So we'll kick it back to the panel now. Proximal cap entry. What is the task that you need to accomplish? What are the tissue characteristics that you're trying to deal with? What's the wire task classification? And what are the required wire characteristics that you're going to want? Maybe we'll ask Dr. Kapadia to chime in on this one.
Sure. This is, of course, not my expertise that, I asked Jay Khatri to do these things. Mm-hmm. But if I had to do it, I would say that, you need to have something that you can feel better, because this is a proximal cap that is in my mind, at least calcified. I couldn't see it very well on the IBIS, but if it is calcified, I would rather use a wire that is not a microchannel kind of tracking wire, but something a little bit more bodied wire. I would, Gaia or Miracle, something like that. I would use this kind of purposes.
So that's perfect. And this is what I wanted the fellows to see, is you see an expert that has experience who may not necessarily do CTO PCI every day, but understands the concept of looking at the problem that needs to be solved and then solving the problem. And what you'll see is these are exactly the fundamentals that you need to consider, right? You need to do a puncture of the proximal cap. It's a blunt cap, and so it's probably calcified and it's probably fibrotic and it's thick. And so you need something that's going to poke through it. You can either do directed navigation or directed penetration. That's the wire classification. And that's why you need a tapered tip, a high tip load, and something that you can feel, something with a hydrophobic tip. So moving forward, this is the wire that I use. It's a Hornet 14, which is an 014 wire, but with a tip that tapers down to 0.008. The coil length is only 15 centimeters, so you can only see it that far. And it's thin, so it means it's gonna bend on you, but the very tip has lots of penetrating power. The penetration force is 432 gram force per millimeter squared. So this compares to a Confianza Pro 12, which is like 390. Okay, so it's important to understand that the structure of the wire, this tapering, and the stainless steel core is what's going to allow you to push through this tough proximal cap. Another wire that Teleflex has put out recently is called the Warrior wire, which is similar. And it's important to recognize you don't need all these wires. You need one for this task classification that you understand and that you use and that you know inside out, backwards, and upside down so that you can predict its behavior. Otherwise, you're going to have shelves upon shelves of wires. Some of them will expire. Your administration will be upset. And most importantly, you won't learn your tools as well as you could. So this is what I did. This is the proximal cap penetration, okay? And you'll see that this is a microcatheter here and a Hornet wire that pokes through that proximal cap. And you can see this little bend in the wire, so that gives you the idea of how much tortuosity there is and how much angulation there is. And pushing through it, you'll even see that there's a buckle in the wire that forms. So I pulled some of the force off of that. And then on the IVIS, you can see this little bright dot here. So that's actually my penetration wire now inside the LAD. That's proof positive that I've entered the proximal cap and I'm within the structure of the vessel, and I can move forward. So Manos, you were wondering about tortuosity and angulation. This gives you an idea of what the angulation is, given that this is in the structure of the vessel. There's a fair number of turns here. And you can see that now we've got a second problem. We need to try to antegrade cross this. How are we going to antegrade cross this if that was our plan? So Ankur, if you're there, what's the task you need to accomplish? What are the tissue characteristics? What's the wire task classification? And what's your opinion on the type of characteristics you need?
Ankur had to leave.
Okay. Do we have any other panel members? I know Dr. Brilakis and Dr. Kapadia are there. Well, Dr. Brilakis, maybe I'll kick this back to you then.
Sure. No, I think that's a great point. So I think there's a key concept here about escalate, de-escalate. That's for CTO PCI and actually other lesions as well, in which you started a very penetrating wire, the Hornet 14, which is great for getting you in, but now you have a tortuosity. So actually the Hornet 14 or any other similar wire is just going to go straight through. So what you're going to do is now to change to something softer, more likely to be able to track through the tissue and not perforate. And a common one would be the Gaia or the Judo series. That's probably the one I would choose. I probably wouldn't use polymer at this point because that's more likely to get you subminimal and you have the concern of the diagonal distal cap.
So precisely what I had hoped you'd say. This is intraplaque crossing through the CTO, but it has to go through the distal cap. It can't go underneath in the subintimal space, because then you'll chop off that distal diagonal. You've got a fibrotic, tortuous, calcified CTO segment. So you need something with some push, some penetration power, but something that you can feel. If you can't feel it, you'll likely get biased to the subintimal space without realizing it, and then you get into that segment situation of chopping off this distal diagonal. You'll need something within the directed navigation wire group, classically the Gaias or the judo wires. And you need something then that you can feel and that you can very carefully direct to exactly where you want it to go. So this is a little bit on the judo wire series. I put these things in again because I intended to be able to give you these slides. I'm not gonna go through the specific details of all of the wires because this can get a little bit complicated, but feel free to read up on them. The basic idea of this wire is that it's got a core to tip design, but it's got a number of coils that are actually stuck to the core wire that extend a long ways down the back of the wire. And so it helps you transmit torque in a one-to-one fashion from the distal end up to the proximal end. That's different than the Gaia wires, which have the Act 1 core that you've, I'm sure, heard about, which are basically 6 wires around the core wire. So you're actually turning each of those wires each time you turn the back of the wire. And that allows you to get better torque responsiveness because it allows for a thinner core, but then it allows for multiple segments to transmit your torque that are not all locked into that big thick core, but instead can be distributed amongst these tiny little wires. And then the X-strand coil, if you can imagine, is another 7 wires around this core of wires. So it's super, super torque responsive, but it's not here available in the US yet. So I did that. I went with the antegrade crossing. I used a Judo 6, and this is not where I wanted to be. And so now I was subintimal, and I ended up subintimal just past the distal cap, which is not what I wanted to do, okay? So this is not good, right? So what do I do here? Is this a problem? Well, D2 is now at risk, and here's why, okay? This is the basics of the anatomy that you have. This is the CTO segment. Here's your proximal cap. Here's your distal cap, okay? Here's your wire into D1, and then there's that wire that's in the CTO segment, but that's now in the subintimal space of D2, right? So blood flow is going to flow along this track, and it's going to start to pressurize this subintimal space, and that's bad because then the subintimal space starts to expand, okay? And eventually expands to the point where, because of antegrade flow, there's branch closure, right? And so then your true lumen ends up way, way down here, and that becomes very, very difficult to regain unless you come retrograde. And coming into a diagonal retrograde is almost obligatorily at the cardio. And so you may end up with branch closure or loss, and then you have an unhappy face there. So how do you protect people from this? Well, one novel way is by using guide extension devices like the trap liner, where you can take this effectively braided straw with a hydrophilic coating on the outside and carefully advance it so that it's right to the tip of the distal cap, but not past it. So that what you do is occlude blood flow into this area, right? This allows you to prevent the subintimal space from pressurizing, and that prevents your big subintimal space here from getting any bigger. That allows you to save the diagonal, and then as long as you come up retrograde and you enter the distal cap on the lower part of the distal cap, not here above where the diagonal comes off, you'll be able to preserve it. So here's a problem where you have precise gear delivery issues in a CTO segment. So I'll take us through this just in the interest of time. We ask the same 4 questions, and really what we want is we need something that has a supportive enough core to be able to deliver bulky gear through a fibrotic segment, but not something that has a bunch of polymer jacket at the end. Otherwise, any movement of that wire may extend that dissection plane. You want something with a moderate core thickness that allow you to track through the CTO segment, but not something so strong that if it does move forward, it'll perforate. A good one is the Asahi Pro Water, where there's a hydrophobic coating at the very tip so you can feel it, and then a hydrophilic coating so that you can help it get through the CTO segment. Though in this case, you would put it through a microcatheter, so that becomes less of an issue. The key is that it has a reasonably supportive core. And so using that, we took a balloon along that wire within the CTO segment, so not beyond the distal cap. That's the most important point, okay? And we balloon tracked this guideline or this trap liner right to the end of that CTO segment, but not beyond the distal cap, which is here. And that's to protect that diagonal, okay? You can see that you're not getting as much flow into here now because a large part of the collateral flow is coming from a really weird conus proximal right collateral. And that's what was primarily filling the diag. And your trap liner is sort of across from it. So you've got to start moving quickly now because the patient's going to start to feel this. And here's where we changed to retrograde. So this was looking at the retrograde options. And you see all this extreme tortuosity here, right? Coming within these little septal collaterals. And if you look carefully, as the heart beats, these septals go in and out, right? They blink, which means they're not very big and they're in the midst of a muscular septum. So what is the task we're trying to accomplish again? And what are the tissue characteristics? What's the type of wire that we need? Well, this is pretty intuitive if you think about it. You're trying to cross really tortuous, really, really tiny vessels that are going through muscle. So you're going to want, and you don't want to tear these vessels open because then you'll lose them as an option, right? It's relatively free tax to tear up a septal unless you make a really big bleed. It's not the same way with epicardioles, which is not something that any of you I think will be doing unless you've done at least 100 septals on your own. So what you want is a wire that you can torque carefully. You have one-to-one torque responsiveness so that you can move it through these challenging areas, and something that's very low tip load, something that's soft so that it can swim through some of the areas where the heart's still beating without poking through the side of the vessel wall. Okay, and these are the collateral crossing group of wires, unsurprisingly, right? Maximally torque responsive, ultra low tip load. And one of the newer ones out there is something called the SHU 03 from Asahi, which has something called a tail wire or a twist wire at the end. So it has a core that comes up with this Act 1 inside of it. So it gives you really good torque response here, but then at the very, very tip, rather than the core, it's just a little twist wire that attaches to the tip of the wire. And what that allows it to do is swim through very tortuous collaterals when the heart's beating. The heart's own beat will move the wire forward. And if it allows that twist wire allows it to engage some of these tortuosities and allows you to wire some of these more difficult collaterals. This gives you an idea of what the tip load is here. So that's what I did, okay? And you can see this retrograde wire coming up here. You can see the title of the slide says retrograde wiring failure. So I'm sure you know where this is going. So you can see this, you can see how it's bending with the heart's beating, but it takes this tortuous turn and manages to make itself up into what I think is the LAD. But this is an extremely important point about CTO PCI, which is that you never, ever, ever put gear along a wire until you know where it is, ever. And you can see that I'm in Pittsburgh somewhere. I'm in a completely different place than where I should be, where the LAD is here and the wire is out here. And so this leads you to wonder what it is that you're doing that's not working. Which tool are you using that's not right? Trust your hands, trust your eyes, trust what you're doing. So I took microcatheters and I tried to map out the septals to try to understand. And I realized that because these septals are closing with each beat, they're the sort of invisible collaterals, and they're not going to respond as well to a twist wire as they might to something that's going to snake and slipperily engage some of these invisible segments. So as you might understand, then that's probably going to be something like a polymer jacketed wire, right? So Manos, recall the wire, retrograde wiring characteristics. What would be the wire that you would use now if you recognize that you had a bunch of invisible septal collaterals to try to get through?
Yeah, so excellent progress so far. I think the wire many people would use is either the Sion Black, which is a wire that is very penetrating. At the same time, you can go places where you don't want to go, but it will often go to those invisible collaterals. The other option is the Fielder XTR.
Yeah, the Fielder XTR is tapered, and so it's also polymer jacketed, and it has a low tip load and can engage. In this case, I ended up using the Sion Black, which again, I won't go through in great detail, but I'll include these things for you and you can have access to them. And so in this case, you'll notice, look at the tortuosity of this septal branch. So this is quite miserable, right? I was surprised when I saw that this is the way the septals move, but this gives you an idea of sometimes how difficult right to left collateral wiring can be. You have to deal with a lot of these types of bends, turns, and tortuosities. And the Sion Black was an ideally suited wire for this because not only are you able to maneuver this along, but the tip, because it has those multiple core wires around it, is not so bad at allowing both tracking along this type of tortuosity, but then also delivery of a microcatheter in experienced hands. Okay, so you can see that this is now where we are, right? And we're looking at these various septals. It's very difficult to figure out which one is going to go where. And so you have to be reasonably careful about how you explore, but understand how the septals work, and then advance when the heart is in diastole, not when it's in systole. And you'll see here that as I advance in diastole, it takes a little bend. You see that at, you know, almost 90-degree angle, and up it goes now without really any manipulation, all the way up the LAD and right down into the diagonal branch distally, right? And along that, then we brought our microcatheter after we confirmed our position, and you can see that we are where we want to be now. So this wire is now in the true lumen of that diagonal branch. And what's worth mentioning is look at how far apart this wire in the true lumen of the diagonal is from this wire in the false lumen. That tells you that dissection segment was not small, and that we should probably be using a microcatheter to try to aspirate some blood before we stent, which is what we ended up doing. So we've solved these problems. Now let's make the retrograde connection. So Dr. Kapadia, now we've got a microcatheter that's going to come up into the mid LAD and is going to need to penetrate the distal cath and enter this trap liner, which is where you want it to be, right? It's in that CTO segment, so you make your connection inside the CTO segment as opposed to beyond the distal cap. So what are the characteristics of a wire that you might want that are going to do that for you? Hello? We may have lost. Oh, Dr. Kapadia,
I'm
there
sorry.
we go.
I was on mute. Yeah, sorry. So I would say that, again, you know, not my personal expertise, but I would say Confianza Pro 12 kind of wire would be a good wire to, you know, get through the distal thing to going to the proximal part.
Okay, so something with a higher tip load that is fairly stiff, so that's going to move relatively straight. We did have some tortuosity here, so you might want maybe a moderate tip load instead of a Confianza Pro 12, maybe a Miracle 6, something where you can feel the distal cap as you advance through it. But certainly a Confianza Pro 12 to breach the distal cap and then try to wire into the guide extension is reasonable. The other option is, again, is one of those directed navigation wires. And so that's what I ended up trying. I actually tried a directed penetration wire, to be honest. I tried a Miracle 6. It's a moderate strength wire, and it's because I thought that the way the microcatheter was sitting was going to bias the wire downwards away from that diagonal branch, and hopefully it would pop in. And this is what we did. So this is the Miracle coming up, and you can see that it comes up. And I was totally wrong. It was biased upwards towards the other wire. And so I didn't really persist with this very much because I realized I was in a place where I didn't want to be. And so in these types of scenarios, you go with the tried and trusted technique, which is reverse card. Reverse card is done when you take a balloon up over your antegrade wire within either the CTO segment or the subintimal space to try to create space and multiple tissue planes through which you can then advance an intraplaque tracking wire like a Mongo or like a Pilot 200 directly through the various dissection planes, taking advantage of its moderate tip load and the lubricity, right, the slipperiness to slip through the various connections that are created and right into your proximal guide. And so that's what we did here, right, where we had taken a balloon up here, and then you can see this little Mongo wire. I'm trying to enter, come back, and then there. And see now the wire is going all the way up the antegrade guide, right? So this Mongo wire has now come down the RCA through the septum, through this microcatheter, and then after ballooning the distal part of the CTO, but again, proximal to the distal cap, we managed to find the connection between the two spaces and then put this slippery wire right through and into the antegrade system through that trap liner. Okay, and that's a little bit about the Mongo. It's an Act 1 core wire, polymer jacketed, moderate tip response, but what makes this wire special is it's got a very abrupt core taper, and so it's really, really good as a tight knuckling, a tight dissection instrument as well. This is the Raider wire from Teleflex. It's got a longer segment with a less abrupt core. It's a little bit higher strength at the tip. This is a way to compare the two with a Pilot 200, which is, as you heard from Dr. Brilakis, the most typical wire that we use. And then finally, Dr. Brilakis, for externalization, what would be your preferred wire in this sort of a scenario and why?
Yeah, great points. I mean, we have two wires, the R350, R303. I think not every lab has everything. We do have R350 in our case, in our lab, so that's one we really use, but I think either one of those would work.
Mm-hmm. So I think I agree with that. The fundamental difference between the RG3, which is it's stainless steel, and the R350, which is nitinol, is that in tortuosity, you want something that is, in moderate tortuosity, something that's kink resistant so that you can deliver things, especially if you're having trouble transiting your microcatheter. That's different than in epicardials where they're very tortuous, where you don't want something that's too kink resistant because then you can actually accord in the epicardial and injure it. And so in this situation, these are the characteristics of the externalization wires that you would want. There's really only two of them, right? As I mentioned. And so we externalize this wire, and you can see this wire slip through, come all the way back down. You can see all the bends that it's going through. You see that very acute bend there all the way out. And so this becomes I was trained by, amongst others, Dimitri Karmpaliotis and Dr. Brilakis through his various talks and in-person teaching sessions. And I remember Dimitri and many of my other mentors used to call this externalization wire the fellow-proof rail, because nobody can lose this wire position so long as you treat it properly. It goes in one guide catheter, in one axis, and literally out the other. And as a result, gives you tons of support. So through this, we were able to perform PCI. And just a word about the importance of intravascular imaging in CTO PCI. This was the initial stent that I put in, which was a 3.5, clearly grossly undersized. And so I post-dilated it to a 4.0 at 22 atmospheres with impunity. I wasn't worried that I would injure the vessel because I knew that it was quite a bit larger than that. And then I got this final result. Okay, and you can see that this diagonal's home and this diagonal's home. Okay, the most important point there was that we preserved both side branches. And here, you have no more right to left collaterals. And that tells you that you've had a successful result because your antegrade flow now predominates. So the portfolio of wires in CTO PCI is huge, and they've dramatically expanded. And so you need to understand how to classify wires into how they're made and what they're supposed to do. Remember tip load, remember core wire, remember coding. As long as you can organize things or understand that you have one wire that modifies each of those three pieces in each task classification, you have the opportunity to get to know your toolbox very, very well, and then get very good at solving these problems as they come up. Remember, systematic problem solving is the secret to your success in CTO PCI. Thanks very much for your time and attention. Sorry if I went a couple minutes over.
No, thank you very much, Sanjog. That was an interesting case, an interesting discussion. I'd like to thank all the presenters and the panel members at this time. I'd like to also thank all the fellows who joined us on this nice sunny August day. We'll see you guys next week. And thank you all. Have a wonderful week and stay safe. Thank you.
Thank you, everyone.
It was a nice presentation. Great. Thanks, Manos.
Great job, Sanjog.
Thanks, everybody.